Welcome, curious minds, to the deep dive. Have you ever stopped to consider that some of the most dangerous, most profoundly impactful infections on human health don't come from massive, terrifying creatures, but from something as small and ubiquitous as a tick, a mite, a flea, or even a tiny louse?
Okay.
And to make matters even more perplexing, these stealthy illnesses often mimic common viral infections, making them incredibly difficult for even expert clinicians to spot early on. It's a true diagnostic challenge.
It truly is. A subtle and insidious problem, wouldn't you say? That initial presentation can be so deceptive, a real minefield, even for the most seasoned medical professionals trying to get to the bottom of what's ailing a patient.
That's precisely why we're here today. Our mission, our deep dive, is to master the intricate world of rickettsial diseases. We've pulled insights from the most authoritative medical sources, dissecting complex medical information, and transforming it into clear, actionable understanding. Our goal for you today isn't just to skim the surface. It's to uncover every crucial detail, empowering you to truly understand this information with the depth and precision of an elite professional in the field.
And we're armed with a comprehensive medical chapter on rickettsial diseases today, guiding us through a truly fascinating group of infections. What's particularly striking about these pathogens is their diverse nature, the unique challenges they pose for accurate diagnosis and effective treatment, and how they subtly but profoundly affect the human body's systems.
Yeah.
We are going to unpack all of that piece by piece.
All right, let's unpack this and truly dive deep. So, to begin our mastery, let's start at the very foundation. What exactly are rickettsia? Because for many of us, it's a term we might have encountered, but the specifics are often, hazy.
Right. Well, at their core, Rickettsiae are a heterogeneous group of very small bacteria. They're classified as obligately intracellular, gram-negative cocobacilli or short bacilli.
Obligately intracellular.
Yeah, that term, obligately intracellular, is crucial. It means they can only survive and multiply inside the living cells of a host. They can't just free float in the environment and thrive independently like many other bacteria.
Okay.
Think of them as microscopic, highly specialized intracellular tenants.
Like tiny, extremely particular parasites, in a way. They need a host cell to even exist.
You've got it exactly. They're completely dependent on host cells for their metabolism and replication. And their primary mode of transmission is typically by a vector, usually a tick, a mite, a flea, or a louse.
Right.
These vectors are, in essence, the biological vehicles, carrying the bacteria from one host to another. What's interesting is that humans are almost always incidental hosts. We're not part of their natural sustained life cycle, which often makes our infection sort of a dead end for the bacteria, preventing further transmission from human to human, with a key exception.
So there's always an exception that breaks the rule, right? What is it?
Indeed. The notable exception is louse-borne typhus, where humans become an integral part of the transmission cycle. Now, here's where it gets really interesting and a bit alarming. Some of these Rickettsiae, specifically Coxiella burnettii, the agent of Q fever, Rickettsia prowazekii, which causes epidemic typhus, and Rickettsia typhi, the cause of marine typhus, possess a remarkable and well-documented ability to survive for extended periods outside of their usual reservoir or vector.
Wow.
This isn't common for obligate intracellular bacteria. And not only can they survive, but they're also extremely infectious in these environmental forms.
Extremely infectious, you say. Give us a truly intriguing fact to illustrate just how potent we're talking about.
Well, consider this potent fact. Inhalation of a single Coxiella burnettii microorganism can be enough to cause pneumonia.
Just one.
Just one. That powerfully underscores the sheer infectivity we're discussing here. It's truly astonishing how minimal an exposure it can take to initiate a serious illness in a human host.
Wow, that's a stark illustration. And that naturally leads us to a more serious, broader implication. With that kind of infectivity and resilience, I imagine some of these pathogens are considered pretty significant threats beyond natural disease.
Absolutely. Due to their high infectivity, especially when they can be inhaled as an aerosol, and the severe debilitating illness they can cause, several rickettsial agents are considered potential bioterrorism threats.
Oh, okay.
This list includes Rickettsia prowazekii, Rickettsia rickettsii, RMSF, Rickettsia tefi, Rickettsia connori, Mediterranean spotted fever, and Coxiella burnettii.
Right.
The ease with which they could theoretically be dispersed as aerosols makes them particularly concerning from a public health and national security perspective, necessitating a deep understanding of their biology.
That's a sobering thought, but it's important to grasp the full spectrum of their implications. Now, you mentioned this is a complex group of pathogens. How do medical professionals even begin to classify or make sense of them, given their diversity? It sounds like trying to categorize a sprawling international family.
You've hit on a core challenge that clinicians and researchers grapple with. Considering rickettsial diseases as a single, uniform entity poses significant difficulties precisely because there are so many different etiologic agents involved.
Right.
Each one comes with its own varied mechanisms of transmission, distinct geographic distributions, and a wide array of disease manifestations in the human body. It's definitely not a one-size-fits-all situation when you're trying to diagnose and treat these.
So, how do they approach this vast landscape? What are the organizing principles?
Well, medical science approaches this from three main classification angles. First, by taxonomy, which involves looking at the diverse microbial characteristics of the agents themselves, their genetic lineage.
Okay.
This broad group includes 7 distinct genera: Rickettsial, Orientia, Ehrlichia, Anaplasma, Neorickettsial, Candidatus Neoehrlichia, and Coxiella. Each of these has its own subtle nuances and biological traits. Second, they're classified by epidemiology, meaning where and how these diseases typically spread in populations, including their vectors and animal reservoirs.
Both the where and how.
Exactly. And third, they're classified by their clinical manifestations, which refers to the specific signs and symptoms they cause in the human body and how those symptoms evolve. Mastering all three classification methods helps to narrow down the possibilities.
That makes perfect sense, offering different lenses to view the same problem. But speaking of clinical manifestations, you hinted earlier that early on they all look remarkably similar. So, what's happening in those initial days when the disease is just getting started?
Yeah, during the crucial first 5 days of illness, the acute presentations of all rickettsial diseases are indeed remarkably similar, making them incredibly hard to differentiate.
Oh.
Patients typically present with fever, a persistent headache, and myalgias, that's muscle aches.
Right.
These are often accompanied by other nonspecific symptoms like nausea, vomiting, or a cough. This constellation of nonspecific flu-like symptoms is precisely why establishing a definitive etiologic diagnosis is very difficult in the acute stage. It's nearly impossible to tell one rickettsial infection from another, or even from a common viral illness, based solely on symptoms during that crucial early window. This is a critical point for clinicians to understand.
So, if it's so challenging to get a definitive diagnosis acutely, how do clinicians even begin to figure it out? What factors should raise their clinical suspicion to consider a rickettsial disease?
That's where the art and science of clinical reasoning truly come together for elite professionals. Heightened clinical suspicion relies heavily on several key factors, often combining broad strokes with minute details.
Okay.
First, epidemiologic data is paramount. This means understanding where the patient has been geographically and what specific environments or activities they've been exposed to recently.
Makes sense.
Second, a very detailed history of exposure to vectors like ticks or mites or to reservoir animals is absolutely crucial. Even if the patient doesn't recall a specific bite, a history of outdoor activity in an endemic area should be a red flag.
Right.
Third, recent travel to endemic locations is a huge pointer.
So it's about connecting the dots. Location, 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 and potential exposure, even subtle ones.
Exactly. Beyond that, clinicians look for specific clinical manifestations that, as the illness progresses, might start to differentiate these diseases.
Okay.
This can include the development of a rash or an eschar. An eschar is a distinct, often black, crusted lesion that forms at the site of a tick or mite bite. But even these can be tricky. Their appearance, timing, and even their presence can vary greatly among the different rickettsial diseases, and sometimes they may even be absent entirely, leading to what we call spotless forms of the disease.
Right. I've heard the rash, particularly in something like Rocky Mountain spotted fever, can be quite subtle or even non-existent in some cases. It's not always the classic presentation.
Precisely. And then there are characteristic laboratory findings that, while not definitive on their own, collectively raise suspicion significantly.
Like what?
These include thrombocytopenia, that's a low platelet count, which are crucial for blood clotting normal or low white blood cell counts, elevated hepatic enzyme levels indicating some stress on the liver, and hyponatremia, which means a low sodium level in the blood.
Okay.
These shared laboratory abnormalities often hint at common underlying pathophysiologic mechanisms across different rickettsial infections, particularly widespread damage to blood vessels.
So it's really about piecing together a complex puzzle where you're looking for these specific pieces, the detailed history, the evolving clinical clues, and these specific lab work patterns to come together.
Yes, and here's the crucial takeaway, the ultimate lesson for the elite professional. When this combination of suspicion is raised, it should immediately prompt empirical treatment.
Don't wait.
You simply cannot afford to wait for definitive lab confirmation, which often takes days or even weeks for rickettsial diseases. The risk of delaying effective treatment, given the potential severity and rapid progression of these illnesses, is simply too high.
Right.
Early intervention is paramount for improving patient outcomes.
And what's the go-to empirical treatment, the first line of defense for most of these infections?
Doxycycline is the empirical drug of choice for the vast majority of rickettsial infections. It's a broad-spectrum antibiotic that has proven highly effective across the board.
Okay.
The only agent that doesn't always respond optimally to doxycycline, or that requires very specific and prolonged treatments for its chronic forms, is Coxiella burnetii, the agent of Q fever, which we'll delve into later with all its unique complexities.
Got it.
But for most of these, doxycycline is the cornerstone of early life-saving intervention.
We've established that the early symptoms of rickettsial diseases are maddeningly nonspecific, making acute diagnosis really tough. But as these illnesses progress beyond those initial flu-like symptoms, how do they evolve? What are some of the diverse and distinct clinical pathways we observe?
That's when the subtle differences among these diseases can start to become more apparent, shifting from a generic illness to something more defined. Beyond the initial fever, headache, and muscle aches, these infections can progress along several principal clinical lines, revealing their more distinct characteristics and often their increasing severity.
Okay, let's talk about rash manifestations first, since that's often what people first associate with tick-borne illnesses. How do they present?
Rashes are indeed a common evolution in many rickettsial diseases. You might initially see a macular or maculopapular rash, which are flat or slightly raised red spots, respectively. This is a common progression.
Okay.
However, some specific rickettsial diseases, such as rickettsial pox, Rickettsia-Parkeri infection, or African tick bite fever, can present with a vesicular rash, meaning small, fluid-filled blisters.
Vesicular, okay.
Yeah, the appearance can be quite varied, which adds to the diagnostic challenge.
And what about that characteristic usher you mentioned earlier? How significant is its presence?
The Escher is a very distinct and highly suggestive lesion, a significant clue for the astute clinician. It's a black, often painless, crusted scab, sometimes described as a tache noire for Mediterranean spotted fever, with an erythematous or reddish halo around it.
Right.
It forms precisely at the site of the tick or mite feeding. What's particularly interesting and important for early detection is that this lesion can actually develop even during the incubation period, before the fever or other systemic symptoms fully manifest.
Oh, wow. Before you even feel sick.
Sometimes, yes.
Huh?
So if you spot an Escher, it's a strong, early, and often definitive clue that a rickettsial or related infection is at play.
So a telltale sign if you know precisely what you're looking for. What about internal manifestations? Does it affect the lungs, for example?
Absolutely. Pulmonary involvement, manifesting as pneumonitis, is a significant and often severe complication in many of these illnesses.
Pneumonitis.
Yeah, patients can develop clear chest radiographic opacities, essentially shadows or haziness on an X-ray and/or rails, which are crackling sounds heard in the lungs. This type of lung inflammation and fluid accumulation is observed in a wide range of rickettsial diseases, including Q fever, severe Rocky Mountain spotted fever, Mediterranean spotted fever, louse-borne typhus, human monocytotropic ehrlichiosis, HME, human granulocytotropic anaplasmosis, HGA, scrub typhus, and murine typhus.
So it's quite common across the board, then.
It is a common and serious progression that requires careful monitoring.
And the brain. Can these pathogens affect the central nervous system? Neurological complications sound particularly concerning.
Yes, neurological complications are another critical and potentially devastating pathway for these infections. Meningoencephalitis, which is inflammation of both the brain and its surrounding membranes, can be a severe manifestation.
Okay.
It's particularly seen in louse-borne typhus, severe Rocky Mountain spotted fever, scrub typhus, human monocytotropic ehrlichiosis, murine typhus, and Mediterranean spotted fever.
Yeah.
While rare, it can also occur in Q fever. These neurological involvements can lead to profound deficits, from confusion and lethargy to seizures and coma, making them a key determinant of patient outcome.
That's incredibly serious. And what about the most severe end of the spectrum when the body's systems truly start to shut down?
At the most severe end, these infections can lead to progressive hypotension, that's a dangerous drop in blood pressure, and ultimately multi-organ failure.
Oh dear.
This mimics severe systemic inflammatory responses like sepsis or toxic shock syndromes. This life-threatening progression, a cascade of systemic failure due to widespread vascular damage and inflammation, is particularly associated with Rocky Mountain spotted fever, Mediterranean spotted fever, louse-borne typhus, murine typhus, scrub typhus, human monocytotropic ehrlichiosis, human granulocytotropic anaplasmosis, and neoehrlichiosis.
Okay.
Recognizing these signs early is paramount for aggressive supportive care.
Here's where it gets really interesting for a clinician. Given this wide range of possible evolving manifestations, how do they connect the dots? What are those crucial epidemiologic clues that can point them in the right direction, like a detective sifting through evidence?
Epidemiologic clues are absolutely vital for connecting a patient's symptoms to a specific rickettsial diagnosis. You need to consider environmental exposure to the specific vectors, ticks, fleas, or mites during their active season in the appropriate geographic regions for specific rickettsiosis.
Right.
For example, knowing the patient was hiking in an area notorious for certain ticks during the spring or summer is a huge piece of the puzzle for suspected spotted fever or ehrlichiosis. It's not just if you were bitten, but where and when you were in certain environments.
Exactly. Travel history to or residence in an endemic geographic region during the known incubation period for these diseases is also a major red flag. And specific animal exposures can be highly indicative. For instance, parturient ruminants, that's cattle, sheep, or goats that are giving birth along with cats and dogs, are key for Q fever. Flying squirrels for Rickettsia prowazekii infection, or even a documented history of previous louse-borne typhus, which can lead to a recrudescent illness known as Brill-Zinsser disease years later. These very specific connections are what allow elite professionals to narrow down the possibilities significantly.
That's exactly it. It's about being a real epidemiological detective, mapping out the patient's recent past against known disease patterns.
And what about those shared pathophysiological insights from lab findings we touched on earlier? What do those common abnormalities tell us about the underlying mechanisms affecting the body?
Right, those common laboratory findings, such as thrombocytopenia, that drop in platelet count, especially common in spotted fever, typhus, ehrlichiosis, anaplasmosis, and scrub typhus. Normal or low white blood cell counts, mild to moderate elevations of hepatic aminotransferases, indicating some liver stress, and hypernatremia, low blood sodium, are more than just isolated markers.
Okay.
They are powerful indicators that suggest some common underlying pathophysiologic mechanisms across these different rickettsial infections, even if the specific bug or its primary vector differs.
Right.
For instance, the consistent drop in platelets often points to widespread endothelial cell damage and increased vascular permeability, that leaky pipe analogy we used earlier, which is a hallmark of many of these diseases. Observing these patterns in lab results provides a window into the body's generalized response to this type of bacterial invasion, helping to paint a clear picture of the systemic nature of these infections.
Okay, we've laid the groundwork and understood the diagnostic challenges. Now, let's truly get into the specifics, starting with the group of tick, mite, louse, and flea-borne rickettsiosis. What's the shared fundamental thread that ties these particular infections together, even with their diverse vectors?
The shared fundamental thread across diseases caused by organisms in the genera Rickettsia and Orientia, which belong to the family Rickettsiaceae, is their primary pathological basis. They all result from the infection of endothelial cells.
The lining of the blood vessels.
Exactly. These are the cells that line the inside of your blood vessels. This infection leads to a subsequent increase in vascular permeability, meaning the lining of your blood vessels becomes leaky. This widespread leakage is precisely where many of the severe systemic symptoms, like swelling and organ dysfunction, originate.
And these pathogenic rickettsial species are quite closely related, aren't they, despite their different names and vectors?
They are indeed. They possess very small genomes, a characteristic often attributed to what's called reductive evolution, where they've lost many genes because they can obtain necessary molecules from inside their host cells.
Ah.
Historically, these bacteria have been separated into two main groups, the typhus group and the spotted fever group, based on their lipopolysaccharide antigens, which are components of their cell walls. This traditional classification has been useful, though genetic analysis has refined our understanding.
So, a strong family resemblance but with distinct personalities and clinical presentations for each illness within those groups.
Exactly. And sometimes the similarities between different diseases and their etiologic agents, even if geographically distinct, are quite striking. For example, Mediterranean spotted fever, North Asian tick typhus, Japanese spotted fever, and Flinders Island spotted fever are caused by closely related organisms within the spotted fever group. Their clinical pictures are so similar that their shared characteristics often outweigh their minor variations, leading to similar diagnostic and treatment approaches, despite their different geographic origins.
That does make diagnosis even trickier in the field when you're dealing with global travel, I imagine. Let's talk about the fatality rates. Which of these are considered the most dangerous, posing the highest risk to life?
For an elite understanding, recognizing the hierarchy of danger is key. The Rickettsiaceae that cause life-threatening infections in decreasing order of their typical case fatality rate are, first, Rickettsia rickettsii, which causes Rocky Mountain spotted fever, RMSF, known for its rapid progression.
Okay.
Next is Rickettsia prowazekii, responsible for louse-borne typhus, historically devastating in epidemics. Then Orientia tsutsugamushi, the agent of scrub typhus, highly prevalent in Asia. Following that is Rickettsial connerii, which causes Mediterranean spotted fever, MSF, particularly dangerous in severe forms. And finally, Rickettsia typhi, the cause of murine typhus, often under-recognized but still with significant mortality. It's also important to note that rarely other spotted fever group organisms can also be life-threatening.
That's a stark and important list to commit to memory. But conversely, are there any spotted fever group, SFG, Rickettsia, that are never documented to cause fatal illness, offering a bit of perspective on the spectrum?
Yes, there are several, which provides a crucial contrast. For example, Rickettsia parkeri, Rickettsia africae, African tick bite fever, and rickettsial pox caused by Rickettsia cari are SFG rickettsia that, while they can cause illness, have never been associated with fatal outcomes in documented cases.
Okay, so some are less severe.
Right. It's also worth noting that the most prevalent SFG rickettsia in the United States, Rickettsial amblyommatis, is often associated with asymptomatic seroconversion in most individuals, meaning they develop antibodies without ever getting sick, or only self-limited milder illness in others. This often skews general reported statistics for spotted fever rickettsiosis downward, making the true danger of something like RMSF seem lower than it actually is when specifically confirmed.
That's a vital distinction. Okay, let's do a deep dive into one of the most infamous and severe of this group, Rocky Mountain spotted fever, RMSF. It sounds intimidating just by its name, and for good reason. ### Rocky Mountain spotted fever, RMSF. A detailed case study.
RMSF, caused by Rickettsia rickettsii, is certainly one of the most serious and rapidly progressive rickettsial diseases. Epidemiologically, it's widespread, occurring in 47 U.S. states, parts of Canada, Mexico, and throughout Central and South America.
Wow, 47 states.
Yeah, and within the U.S., you'll find the highest prevalence in the South, Central, and Southeastern states, where environmental conditions and tick populations are conducive.
And what about the specific tick vectors that transmit it, since that's so crucial for understanding exposure risk?
It's transmitted by various tick species, which vary by geographic region. In the eastern two-thirds of the U.S. and California, the primary vector is the American dog tick, Dermacentor variabilis.
Okay.
In the western states, it's predominantly the Rocky Mountain wood tick, Dermacentor andersoni.
Okay.
In Mexico, Arizona, and Brazil, the brown dog tick, Rhipicephalus sanguineus, is often the culprit, and various amblyoma species transmit it throughout Central and South America. The Rickettsia organisms are acquired by ticks primarily through transovarial transmission, meaning the infection passes directly from a mother tick to her offspring, or by co-feeding adjacent to an infected tick, or by ingesting a blood meal from rickettsymic small mammals. This creates a persistent reservoir.
So humans typically get infected when these ticks are most active and abundant?
Precisely. In the Northern Hemisphere, human infections usually occur from April to September, which is peak tick season. This is a critical time window for clinicians to consider RMSF in febrile patients. However, it's important to remember that some cases can occur outside this typical window, especially in warmer climates or during unusual weather patterns.
You mentioned mortality rates earlier, and how the commonly reported low rates for general spotted fever rickettsiosis can be misleading. Can you elaborate on the true mortality for confirmed RMSF?
That's a crucial point for accurate understanding. A recently reported low mortality rate of 0.4% for general spotted fever rickettsiosis is, unfortunately, largely an artifact.
Okay.
It's because there are so many less pathogenic SFG species out there, like Rickettsial amblyommatis, and a relatively low proportion of cases are diagnostically confirmed specifically as Rickettsia infection.
Right, the broad testing issue.
Exactly. When you isolate and look at truly confirmed cases of RMSF, where Rickettsia is the sole infecting SFG species, the reported case fatality rates in the U.S. and in parts of Arizona are much, much higher, around 9% to 10%.
9 to 10%. That's significant.
It is. This means the true danger of RMSS is significantly underestimated by broad surveillance data.
So the actual risk for a confirmed case is quite high. And who's most vulnerable to a fatal outcome?
The case fatality rate is demonstrably highest among children under 10 years of age and in individuals over 70. For reasons that are not yet fully understood, the case fatality rate of RMSF in Mexico and Brazil can approach a staggering 50%.
50%? Wow.
Yeah. This highlights a critical unanswered question about the complex interplay of host factors, bacterial strains, and healthcare access that influence disease severity and outcome in different regions. This is an area of ongoing research.
Wow, that's an immense difference in mortality. Let's delve into the pathogenesis.
Yeah.
How does Rickettsial actually cause such widespread damage in the body beyond just inhabiting cells? What's the core mechanism?
Okay, so the destructive process begins when Rickettsia organisms are inoculated into the dermis, the skin layer, from the tick's salivary glands. This typically requires at least 6 hours of feeding for a sufficient number of bacteria to be transmitted.
6 hours.
Okay.
From that initial site, the Ricketsiae spread efficiently throughout the body via the lymphohematogenous route, meaning they travel through both the lymphatic system and the bloodstream. They then infect numerous foci of contiguous endothelial cells, which are the specialized cells that form the inner lining of all your blood vessels, from the largest arteries to the tiniest capillaries. The incubation period, from tick bite to symptom onset, is usually about a month, but can range from 2 to 14 days.
And once those endothelial cells are infected, what happens? Is it like a clot forming and blocking blood flow, causing damage that way?
That's a common misconception, and understanding the true mechanism is vital for clinical mastery. Occlusive thrombosis, meaning blood clots completely blocking vessels, and ischemic necrosis tissue death due to lack of blood flow are not the fundamental pathological basis for tissue and organ injury in RMSF.
Oh, okay, so not clots.
Not primarily clots, no. This is a critical distinction. Instead, the primary mechanism of injury is a profound increase in vascular permeability.
The leaky pipes again. Exactly. The infected endothelial cells become dysfunctional and leaky, allowing fluid and proteins to escape from the blood vessels into the surrounding tissues. This widespread leakage leads to edema, swelling, hypovolemia, a decrease in effective blood volume, and ischemia, reduced blood flow to tissues due to the fluid shift, which is then responsible for the extensive tissue and organ damage seen in severe RMSF.
So it's more like the body's entire circulatory plumbing system becomes leaky rather than being clogged.
An excellent, very clear analogy.
Well,
The fluid leaks out, not only causing swelling, but also depleting the effective circulating blood volume, leading to shock.
Right.
This widespread leakage also triggers a consumption of platelets, resulting in thrombocytopenia, a low platelet count in a significant portion of patients, ranging from 32% to 52%. However, disseminated intravascular coagulation, DIC, which is a severe life-threatening clotting disorder characterized by both widespread clotting and severe bleeding with very low fibrinogen levels, is actually rare in RMSF. The activation of platelets and the generation of thrombin that do occur appear to be primarily homeostatic responses to the endothelial injury, forming non-occlusive plugs rather than the large obstructing clots.
Fascinating. And a very precise understanding of the disease process. So let's go to the bedside now. What are the clinical manifestations, particularly early on when it's so difficult to distinguish from other common illnesses?
Early in the illness, RMSF is indeed extremely difficult to distinguish from many common self-limiting viral illnesses. The most common symptoms presenting during the first 3 days are a persistent fever, often high, a severe headache, generalized malaise or a feeling of being unwell, widespread myalgia, muscle aches, and often nausea, vomiting, and anorexia, loss of appetite.
Sounds like a bad flu.
Exactly. This non-specific flu-like presentation is precisely why it's so often missed and undertreated in its critical early phase. Many patients are initially misdiagnosed with a viral infection and don't receive appropriate life-saving treatment until much later when they are already severely ill and frequently require intensive care.
You talked about the rash earlier and how variable it can be, not always the classic presentation. How does it typically manifest and progress in RMSF?
The rash is a clear manifestation of the progressive nature of the widespread vascular damage. But it's crucial to understand it's not always an early or classic sign.
Okay.
It's only evident in a minority of patients, about 14% on the very first day of illness, and only 49% during the first 3 days. It typically starts as small, flat red spots called macules, usually measuring between 1 and 5 millimeters. These macules usually appear first on the wrists and ankles, and then spread towards the rest of the extremities and the trunk in what's known as a centripetal progression.
Okay, wrists and ankles first.
Usually. As the vascular damage worsens, these maculopapules, which are slightly raised red spots, can develop frank hemorrhage at their center, producing petechia, which are small, pinpoint spots of bleeding under the skin that do not disappear when you press on them. This signals more severe capillary damage.
So it's not always the textbook rash, and it often appears late, potentially delaying diagnosis?
Exactly. The rash is notoriously variable. It can appear on day 6 or even later in 20% of cases. And critically, in a significant proportion between 9% and 16%, it may not appear at all, leading to spotless RMSF.
Spotless RMSF, okay.
Petechiae, the hallmark of more severe vascular damage, occur in 41% to 59% of cases, but typically appear on or after day 6 in 74% of cases that do manifest a rash.
Right.
Involvement of the palms and soles, which is often considered a highly diagnostic feature and frequently taught as a classic sign, also usually develops relatively late after day 5 in 43% of cases, or not at all in a large proportion, 18% to 54% of cases.
Wow.
So relying solely on the classic rash presentation, especially one involving palms and soles, can lead to a dangerously delayed diagnosis and poor outcomes.
What about the systemic effects beyond the skin? How does RMSF impact other major body systems?
The systemic impact is profound, affecting multiple organ systems due to the widespread vascular injury. The widespread vascular leakage we discussed earlier leads to hypovolemia, a decrease in effective blood volume, which in turn can cause prerenal azotemia, a form of kidney dysfunction due to reduced blood flow, and in 17% of cases, hypotension, low blood pressure.
Okay.
Infection of the pulmonary microcirculation, the tiny blood vessels in the lungs, can lead to non-cardiogenic pulmonary edema, a type of fluid accumulation in the lungs not caused by heart failure. This is severe, with 12% of patients developing acute respiratory distress syndrome, ARDS, a life-threatening lung injury, and 8% requiring mechanical ventilation to breathe. Cardiac involvement, manifesting as dysrhythmias, irregular heartbeats, is also observed in 7% to 16% of cases.
You've emphasized that CNS involvement is a key determinant of patient outcome. How does RMSF affect the brain and nervous system, and what are the specific manifestations?
CNS involvement is indeed critical and often signifies severe disease. Encephalitis, inflammation of the brain itself presenting as confusion or lethargy, is apparent in a significant proportion, 26% to 28% of cases.
Right.
As the encephalitis progresses, it can manifest as more severe altered mental states, such as stupor or delirium in 21% to 26% of cases, loss of coordination or ataxia in 18%, progression to coma in 10%, and seizures in 8%.
Wow.
Numerous focal neurological deficits affecting specific parts of the brain have also been reported. Meningoencephalitis, which is inflammation of both the brain and its surrounding membranes, results in cerebrospinal fluid, CSF pleocytosis, an increase in white blood cells in the spinal fluid in 34% to 38% of cases.
Okay.
This is typically a mononuclear predominance, meaning lymphocytes and monocytes, though occasionally higher cell counts and even the neutrophils can be seen. CSF protein is increased in 30% to 35% of cases, but the CSF glucose concentration usually remains normal, which helps distinguish it from some bacterial meningitis.
What about other major organs? Does it hit the kidneys or liver significantly?
Yes, RMSF can severely affect these organs. Acute kidney injury can occur, often reversible with aggressive rehydration and fluid management. But in severe cases associated with shock, it's caused by acute tubular necrosis, direct damage to kidney tubules. Hepatic injury, indicated by increased serum aminotransferase concentrations, markers of liver stress, in 38% of cases, is due to multifocal death of individual liver cells. However, it typically does not lead to full hepatic failure.
Okay, that's good to know.
Jaundice, a yellowing of the skin, is recognized in 9% of cases, and an elevated serum bilirubin concentration in 18% to 30%. Life-threatening bleeding is rare, but anemia develops in 30% of cases, severe enough to require blood transfusions in 11%. Blood is detected in the stool or vomitus of 10% of patients, and tragically, death can follow massive upper gastrointestinal hemorrhage in the most severe cases.
And what do the broader laboratory findings tell us beyond those specific organ markers?
Other characteristic clinical laboratory findings provide further clues. You'll typically see increased plasma levels of acute phase proteins like C-reactive protein, CRP, fibrinogen, and ferritin, all indicating a robust systemic inflammatory response.
Okay.
Hypoalbuminemia, low blood albumin, and hyponatremia, low blood sodium, seen in 56% of cases, are often due to the appropriate secretion of antidiuretic hormone in response to the hypovolemic state caused by vascular leakage.
Right.
Myositis, or muscle inflammation, occurs occasionally with marked elevations in serum creatine kinase levels and multifocal rhabdomyonecrosis, which is breakdown of muscle tissue. Ocular involvement can include conjunctivitis in 30% of cases, as well as more severe retinal findings like vein engorgement, flame hemorrhages, arterial occlusion, and papilledema, even with normal CSF pressure in some instances, reflecting the systemic vascular damage.
This sounds like a rapid, full-body assault. What determines the severity and outcome for patients with RMSF?
Severe RMSF can quickly present as a full-blown sepsis or septic shock, mimicking other critical illnesses, which underscores the diagnostic challenge. In untreated fatal cases, death typically occurs within 8 to 15 days after symptom onset.
8 to 15 days. Very quick.
Very. There's also a rare, extremely aggressive presentation known as fulminant RMSF, which is fatal within 5 days of symptom onset. This fulminant form is seen most often in male black patients with glucose 6-phosphate dehydrogenase G6PD deficiency, possibly related to an undefined host factor that influences the disease course.
Wow.
Tragically, even with treatment, severe illness can lead to lasting sequelae, including permanent neurologic deficits and gangrene of the extremities, sometimes necessitating amputation. The rapidity and severity demand immediate clinical recognition.
Okay, given how complicated and fast-moving this can be, how do you actually diagnose RMSF with the precision required for an elite professional? What are the key diagnostic tools and challenges?
The diagnosis of RMSF in the acute stage is genuinely more difficult than often appreciated. The single most important epidemiological factor is a history of exposure to a potentially tick-infested environment within the 14 days preceding disease onset, particularly during the known tick activity season. However, it's crucial to remember that only about 60% of patients actually recall being bitten by a tick during the incubation period. So a negative recall of a tick bite does not rule out RMSF.
Right, you can't rely on that. So the differential diagnosis must be incredibly broad in the early stages. What else could it be confused with, making it a true diagnostic puzzle?
It is indeed broad, which makes it challenging. Early clinical manifestations, fever, headache, and myalgia without a rash can mimic common viral illnesses like influenza, enteroviral infections, or infectious mononucleosis.
Okay.
Can also be confused with other infections such as viral hepatitis, leptospirosis, typhoid fever, various bacterial sepsis syndromes, human monocytotropic ehrlichiosis, human granulocytotropic anaplasmosis, marine typhus, sylvatic flying squirrel typhus, and Rickettsial pox.
A long list.
Yeah. If there's prominent nausea, vomiting, and abdominal pain, it can even suggest a gastrointestinal infection, or, alarmingly, has led to unnecessary exploratory laparotomies due to suspected acute abdomen.
Oh my.
When CNS involvement is present, it can be misdiagnosed as bacterial or viral meningoencephalitis. And if cough, pulmonary signs, or chest radiographic opacities are present, it can be mistaken for bronchitis or pneumonia caused by other pathogens. The breadth of possibilities is why an astute clinician must keep RMSF on their radar.
So if a patient comes in with general flu-like symptoms during tick season, it should always be on the radar for an elite professional, even if that classic rash isn't immediately obvious.
Absolutely. This is a key insight for mastery. At presentation during the first 3 days of illness, a mere 3% of patients exhibit the classic triad of fever, rash, and a history of tick exposure.
Only 3%.
Yeah. When a rash does appear, RMSF should definitely be considered. But remember, many other illnesses can cause a rash too, like measles, rubella, meningococemia, disseminated gonococcal infection, secondary syphilis, toxic shock syndrome, or drug hypersensitivity reactions.
All right.
Conversely, anyone in an endemic area presenting with a provisional diagnosis of one of these other rash-associated illnesses could actually have RMSF. So if a suspected viral infection or other febrile illness worsens over a couple of days during RMSF season, the patient must be reevaluated immediately for RMSF, and empirical treatment should be considered without delay.
What about laboratory tests? Are there specific tests for RMSF that provide a definitive diagnosis?
The most common serologic test for confirmation is the indirect immunofluorescence assay, or IFA. However, it's critical to understand that a reactive antibody titer is usually not detectable until 7 to 10 days after symptom onset.
So too late for the acute phase.
Exactly. This means that serologic tests for RMSF are typically negative at the time of initial medical care, precisely when the patient is most acutely ill and needs diagnosis. Therefore, the absolute rule for an elite clinician is that treatment should not be delayed while awaiting a positive serologic result.
Crucial point.
Waiting for serology can, quite literally, be fatal. While the sensitivity and specificity of the indirect immunofluorescence IG assay are very high, 89% to 100% and 99% to 100% respectively, they only become useful after the antibodies have had time to develop.
Right.
IgM antibody detection isn't more sensitive in early illness and can be subject to nonspecific cross-reactivity, making it less reliable.
So if serology is usually too late for acute diagnosis, what is the key diagnostic test that can be useful during the acute illness?
For acute diagnosis, the only test that is proven truly useful during the acute illness, particularly if a rash is present, is immunohistologic examination of a cutaneous biopsy sample taken directly from a rash lesion.
A skin biopsy.
Yes. A 3 mm punch biopsy from such a lesion has a sensitivity of 70% and a specificity of 100% for detecting Rickettsia rickettsii. Polymerase chain reaction, PCR, specifically targeting Rickettsia DNA on a rash biopsy, would likely yield even higher sensitivity.
Okay.
However, PCR amplification for detection of Rickettsia DNA in peripheral blood is not adequately sensitive. This is because although Rickettsia are abundant in heavily infected endothelial cells lining vessels, their quantities in the general circulation in the blood are relatively low.
Got it.
Cultivation of Rickettsia in cell culture is technically feasible, but it's rarely undertaken in clinical labs due to its technical difficulty and serious biosafety level 3 biohazard concerns.
And the recent increase in reported RMSF cases in the U.S., is that a true surge in the disease or something else at play?
This is a nuanced point. The recent dramatic increase in the reported incidence of RMSF correlates largely with the widespread use of single titer spotted fever group, SFG, cross-reactive enzyme immunoassay serology.
The broad tests again.
Exactly. This means that many cases identified by these broader, non-specific tests are not specifically confirmed to be caused by Rickettsia rickettsii. It's suspected that many febrile individuals who don't actually have severe RMSF are presenting with cross-reactive antibodies, possibly due to previous exposure to the highly prevalent SFG Rickettsia amblyommatis, which, as we discussed, generally causes much milder or even asymptomatic infections.
Right.
So it's potentially an artifact of broad testing, rather than a true surge in the most dangerous confirmed form of RMSF, though vigilance remains critical.
So it's a case of potential overdiagnosis of the severe form due to broad testing, rather than a true surge in the most dangerous R. rickettsii cases. That clarifies a common misunderstanding. Now let's talk about treatment. Given the severity and rapid progression of RMSF, what's the immediate go-to approach?
The immediate crucial go-to for treatment of both children and adults with RMSF is doxycycline.
Doxycycline again.
Yes. Because of the severity of RMSF and its potential for rapid deterioration, immediate empirical treatment with doxycycline is indicated in any patient presenting with symptoms in an appropriate epidemiologic setting, even before diagnostic confirmation.
Right.
Doxycycline is administered orally or intravenously if the patient is comatose or vomiting, at a dose of 100 milligrams twice daily.
There's often significant concern about giving tetracyclines like doxycycline to children because of the risk of permanent dental staining. Is that still a major issue here, or is the severity of RMSF prioritized?
That concern is certainly weighed, but in the context of RMSF, the severity of the disease and its potential for fatal outcomes far outweighs the risk of minor dental staining.
Okay.
For children with suspected RMSF, current guidelines recommend that up to 5 courses of doxycycline may be administered with minimal, often imperceptible, risk of dental staining. The benefit of preventing severe disease or death is paramount.
Right.
In patients with a true allergy to doxycycline, desensitization should be strongly considered because of how critical this medication is for survival.
What about alternatives, especially for pregnant patients, where doxycycline might traditionally be avoided?
Chloramphenicol was once considered an alternative during pregnancy. But it's important to know it's generally less effective than doxycycline for RMSF, and its availability is often an issue in many regions, including the United States.
Okay.
Fortunately for doxycycline, there is actually little evidence to support the occurrence of tetracycline-associated adverse events, such as hepatotoxicity in mothers or staining of deciduous teeth and teratogenicity in fetuses, in pregnant individuals who receive doxycycline for short courses or in cases of severe rickettsial disease.
That's good news.
Yes. The anti-rickettsial drug should be administered until the patient is febrile and clinically improving, which is usually for a period of 3 to 5 days after the fever resolves.
And what treatments should absolutely be avoided? It sounds like there are some common antibiotics that could actually make things worse.
That's a critical piece of knowledge for any professional. It's crucial to know what not to use. Beta-lactam antibiotics like penicillin and its derivatives, erythromycin and aminoglycosides, have absolutely no role in the treatment of RMSF and should be avoided.
Okay.
Furthermore, sulfa-containing drugs like trimethoprim sulfamethoxazole are actually associated with worse outcomes in RMSF patients than no treatment at all.
Worse? Wow.
Yes. There's also very little clinical experience with fluoroquinolones, chlorothromycin, and azithromycin for RMSF, so these are generally not recommended due to lack of efficacy data in a disease this severe.
Beyond antibiotics, what kind of supportive care is needed for the seriously ill, given the multisystemic damage we've discussed?
The most seriously ill patients, often those who present late or have rapid progression, require meticulous management in intensive care units. This involves careful fluid administration to optimize tissue perfusion without precipitating non-cardiogenic pulmonary edema, which is a major complication. Some severely ill patients require intubation and mechanical ventilation for hypoxemia, renal replacement therapy for oliguric or anuric acute renal failure, anti-seizure medication for seizures, and transfusions of packed red blood cells for anemia or severe hemorrhage, or platelet transfusions for severe thrombocytopenia.
A lot of support needed.
It's a comprehensive, full-court press of supportive care, addressing every affected organ system alongside targeted antibiotic therapy.
Finally, what can individuals do to prevent RMSF? It sounds like avoidance is key.
Prevention is indeed centered on avoiding tick bites. This means wearing protective clothing, especially in wooded or grassy areas, applying tick repellents containing DEET or picaridin, conducting thorough body inspections once or twice a day after outdoor activities, and promptly removing any attached ticks using fine-tipped tweezers before they can inoculate the Rickettsial, as transmission usually requires several hours of feeding.
Right, get them off quick.
Exactly. It's also important to note that prophylactic doxycycline treatment of tick bites has no proven role in preventing RMSF and is not recommended. The focus is on vigilance and immediate removal.
So it's about constant awareness and rapid response, not pre-treatment. Let's briefly touch on some other spotted fevers now, understanding their key distinguishing features. #, other spotted fevers, brief highlights.
Sure. First, Mediterranean spotted fever, MSF, caused by Rickettsia cannori, is widely prevalent in southern Europe, parts of Africa, the Middle East, and Central Asia.
Okay.
It's characterized by high fever, a generalized rash, and in most regions, a very distinctive inoculation eschar, known as a tache noire, black spot, at the site of the tick bite, often appearing even before the fever.
The tache noire.
Yes. A severe form of this disease, with a mortality rate that can reach up to 50%, primarily occurs in patients with underlying conditions like diabetes, alcoholism, or heart failure.
What about African tick bite fever? Given its name, I assume it's prominent there.
African tick bite fever, caused by Rickettsia africa, occurs in rural areas of sub-Saharan Africa and the Caribbean. It's transmitted by amblyomma ticks, which often feed in groups, leading to the characteristic development of multiple eschars, a key distinguishing feature.
Multiple eschars, okay.
The illness is typically milder than RMSF, presenting with headache, fever, eschars, and regional lymphadenopathy. The rash may be vesicular, sparse, or even absent. Due to the increasing popularity of African safaris and tourism, this is actually the rickettsiosis most frequently imported into Europe and North America by travelers.
And a similar one, maculatum disease.
Yes, maculatum disease is caused by Rickettsia parkeri, a closely related species. It's found in the U.S. and South America, transmitted by amblyomma maculatum and other amblyomma ticks. Its clinical presentation is quite similar to African tick bite fever, often involving an eschar and a generally mild course.
Okay. What about rickettsial pox? That sounds like something out of a historical medical text or perhaps a curious case study?
Rickettsial pox, caused by Rickettsia acari, is quite fascinating and often under-recognized. It primarily infects mice and their mites, Leponosoides sanguinis, which maintain the organisms via trends of aerial transmission.
Mice and mites.
Yep. While principally recognized in New York City, cases have been reported in other urban and rural U.S. locations and internationally. It gained some notoriety because investigations into eschers initially suspected of being bioterrorism associated to cutaneous anthrax actually revealed that rickettsial pox was occurring more frequently than previously thought, highlighting its potential for misdiagnosis.
What does rickettsial pox look like clinically?
The clinical presentation is quite distinctive. At the site of the mite's feeding, a papule forms, which then develops the central vesicle and subsequently becomes a 1 to 2.5 centimeter painless, black, crusted escher surrounded by an erythematous halo.
Okay.
Regional lymph node enlargement often suggests initial lymphogenous spread. After an incubation period of 10 to 17 days, during which the escher and lymphadenopathy might go unnoticed, the disease onset is marked by malaise, chills, fever, headache, and myalgia. A macular rash appears 2 to 6 days after onset and typically evolves sequentially into papules, vesicles, and then crusts that heal without scarring. Sometimes the rash remains macular or maculopapular throughout.
Right.
Other nonspecific symptoms can include nausea, vomiting, abdominal pain, cough, conjunctivitis, or photophobia. Without treatment, the fever usually lasts 6 to 10 days, making it generally a self-limited but uncomfortable illness.
And diagnosis and treatment for rickettsial pox?
Diagnosis is typically made based on the distinct clinical presentation and epidemiologic findings, followed by convalescent serology for a spotted fever group rickettsiosis. Often, further testing to identify the exact rickettsia species is not pursued, as the clinical picture is fairly unique.
Okay.
Doxycycline is the drug of choice for treatment, and it typically leads to a prompt resolution of symptoms.
Any other notable spotted fevers that elite professionals should be aware of?
Yes, there's also flea-borne spotted fever, caused by Rickettsia felis, which is suspected to be an emerging rickettsiosis worldwide. It's maintained transovarially in the cat flea, Stenocephalidis felis, making our common house pets a potential vector.
Cat fleas.
Yeah. It's described as a moderately severe illness with fever, rash, headache, and sometimes central nervous system, gastrointestinal, and pulmonary symptoms. Interestingly, PCR can often detect these organisms in healthy individuals, and patient isolates and strong serologic support has sometimes been lacking, making its definitive characterization and understanding of its true burden a bit challenging.
So even our feline friends can be silent carriers of these tricky diseases. Let's now pivot to a disease with a profound human history, often driven by societal conditions and a completely different vector. Epidemic, louse-borne typhus, #tag epidemic louse-borne typhus, Rickettsia prowazekii, a historical and modern threat.
Epidemic typhus, caused by Rickettsia prowazekii, has a truly profound and often devastating historical impact, frequently haunting regions afflicted by wars, famine, and natural disasters. It's primarily transmitted by the human body louse, Pediculus humanus corporus, which thrives in poor hygienic conditions, overcrowding, and cold environments where people don't change or wash clothes frequently.
So it's intrinsically linked to human suffering and specific social conditions. How does the louse transmit it?
Lice acquire Rickettsia prowazekii when they ingest blood from a rickettemic patient, someone with the bacteria in their bloodstream.
Okay.
The Rickettsia then multiply rapidly in the louse's midgut epithelial cells and are shed in his feces. When an infected louse leaves a febrile person and feeds on a new uninfected host, it deposits infected feces on the skin.
Right.
The new host then inadvertently inoculates the organisms by scratching the intensely itchy louse bites, rubbing the infected feces into the broken skin.
Ah, the scratching.
Yes. Crucially, and quite tragically for the louse itself is killed by the Rickettsia after about 1 to 2 weeks and cannot pass the infection to its offspring. This explains why it thrives in conditions of human displacement and lack of hygiene. As people move, so do the infected lice. Frequent outbreaks have been reported in places like Algeria, Peru, and Rwanda, directly tied to such conditions. Beyond the human louse cycle, there's also a zoonotic cycle involving eastern flying squirrels, Golcomys volans, and their associated lice and fleas, which can also transmit Rickettsia prowazekii to humans, leading to sporadic cases.
And what about Brill-Zinsser disease? That sounds like a fascinating, insidious twist on the infection where it can reappear years later.
Brill-Zinsser disease is a classic and very important example of a recrudescent illness. It occurs years, sometimes even decades, after an initial acute epidemic typhus infection, likely as a result of waning immunity. The Rickettsia prowazekii organisms can remain latent or dormant in the body for years, possibly in the lymphatic system or central nervous system. Their reactivation can then lead to sporadic cases of the disease, even in louse-free populations. or contribute to new epidemics if conditions for louse transmission return.
Okay.
Recrudescence has even been documented after flying squirrel-associated typhus, highlighting the long-term persistence of the pathogen within a host. This phenomenon is a critical factor for clinicians to consider, especially in older patients or those with a history of living in endemic regions.
And this ties back directly to our earlier point about bioterrorism, doesn't it? Its potential as a weapon.
It absolutely does. Rickettsia prowazekii is definitely considered a potential agent of bioterrorism. Infections with it have high case fatality ratios. They cause diseases that are difficult to diagnose early on due to their nonspecific flu-like symptoms. And critically, they're highly infectious when inhaled as aerosols. The concern is further heightened by the fact that organisms resistant to tetracycline or chloramphenicol have unfortunately been developed in the laboratory, complicating potential treatment strategies in a mass casualty scenario.
Let's talk about the clinical picture of epidemic typhus itself from a patient's perspective.
After an incubation period of about 1 to 2 weeks, the onset of illness is characteristically abrupt and severe, often beginning with profound prostration, a severe headache that's often incapacitating, and a high fever rapidly rising to between 38.8 degrees C and 40.0 degrees C, 102 degrees E or 204 degrees.
Very high fever.
Yes. A persistent cough is a prominent symptom, developing in 70% of patients, and generalized myalgias are usually severe. A distinctive rash typically begins on the upper trunk around day 5 and then generalizes to the entire body, notably sparing the face, palms, and soles.
Okay, spares face, palms,
Yeah.
soles.
Initially macular, flat red spots, it quickly becomes maculopapular, slightly raised spots, then petechial, small red-purple spots from bleeding under the skin, and can even become confluent, merging together if untreated, indicating severe vascular damage.
And that rash, like with RMSF, can be tricky to spot on certain skin tones, correct?
Yes, it's a critical point for clinicians globally. The rash often goes undetected on darkly pigmented skin. In fact, up to 60% of African patients can present with what's called spotless epidemic typhus, where the rash is either absent or not visible.
Wow, 60%.
Yeah. Other common signs include photophobia, sensitivity to light, with significant conjunctival injection, red eyes, a dry, furred tongue, progressive confusion, and even coma in severe cases. Skin necrosis and gangrene of the digits, as well as interstitial pneumonia, can also occur in severe illness. The untreated disease is fatal in 7% to 40% of cases, primarily depending on the host's underlying condition and age. Patients often develop renal insufficiency and widespread multi-organ involvement, with neurological manifestations being particularly prominent, affecting 12% of patients overall.
Okay.
Interestingly, the infection associated with North American flying squirrels tends to be a milder illness, though it's unclear if this is due to host factors or attenuated virulence of the specific Rickettsial prowazekii strain.
Given all that, how do you diagnose and treat epidemic typhus, particularly in the challenging environments where it often occurs?
Epidemic typhus is unfortunately sometimes misdiagnosed as typhoid fever in tropical countries due to similar symptoms, which adds to the diagnostic challenge and delays appropriate treatment.
Right.
In settings where louse-borne typhus outbreaks occur, the means for even basic serologic studies are often unavailable. Therefore, epidemics are usually recognized not by individual lab tests, but by the serologic or immunohistochemical diagnosis of a single confirmed case within a susceptible population, or by the actual detection of Rickettsia prowazekii in a louse found on a patient.
So based on the outbreak context.
Often, yes. This highlights the importance of epidemiological surveillance.
So it's often a diagnosis based on the larger picture of an outbreak or finding the vector.
In treatment.
For treatment, doxycycline at 100 milligrams twice daily is administered orally or intravenously if the patient is comatose or vomiting, and continued until 3 to 5 days after defervescence, resolution of fever.
Under severe epidemic conditions where resources are strained, a single 200 milligram oral dose can be attempted, but it has been known to fail in some cases, so a multi-day course is preferred. For pregnant patients, chloramphenicol is traditionally considered early in pregnancy and doxycycline late in pregnancy, but this requires individual evaluation by a specialist.
And prevention, of course, is about controlling the vector, the human body louse.
Exactly. Prevention of epidemic typhus hinges on effective control of human body lice. This involves basic but critical public health interventions, regularly changing and laundering clothes in hot water, and using insecticides every 6 weeks to control the louse population in affected communities. It's a direct public health intervention focused on breaking the transmission cycle between humans and lice.
Let's turn our attention now to endemic murine typhus, which seems to be a global under-recognizer despite its prevalence. Hashtag endemic murine typhus Rickettsial.
A global under-recognizer. Endemic murine typhus caused by Rickettsia typhus is indeed often significantly under-recognized, despite its widespread prevalence globally. It's primarily maintained in mammalian host flea cycles, with rats, specifically the black rat, Rattus rattus, and the Norway rat, Rattus norvegicus, and the oriental rat flea, Xenopsilochiopus, being the classic zoonotic niche.
Rats and fleas.
Yes, fleas acquire Rickettsia typhi from rickettemic rats and carry the organism throughout their lifespan.
How do humans typically get infected, given the flea connection?
Non-immune rats and humans are primarily infected when Rickettsia-laden flea feces contaminate pruritic, itchy bite lesions from the fleas.
Oh, the flea dirt again.
Exactly. As individuals scratch these itchy bites, they inadvertently rub the infected flea feces into the broken skin. While less frequent, direct flea bites can also transmit the organisms. Interestingly, transmission can also occur via the inhalation of aerosolized Rickettsiae from flea feces, making airborne transmission a possibility in contaminated environments.
Right.
Infected rats, despite carrying the bacteria, appear healthy, but are rickettemic for about 2 weeks, serving as a silent reservoir.
And where is this found geographically, given it's a global under-recognizer?
Murine typhus is mainly seen in specific geographic regions of the U.S., notably Texas and Southern California, but it is highly prevalent and often unrecognized globally in warm, often coastal areas throughout the tropics and subtropics.
Okay.
The incidence typically peaks from April through July in Texas and during the warm months of summer and early fall in other geographic locations correlating with flea activity. A key diagnostic challenge is that patients seldom recall exposure to fleas, though nearly 40% report exposure to animals like cats, opossums, and rats, which can also carry infected fleas into human environments.
So a hidden threat that's widespread but hard to pinpoint. What are the clinical manifestations in humans?
The incubation period for murine typhus averages around 11 days, with a range of 8 to 16 days. Symptoms like headache, myalgia, muscle aches, arthralgia, joint pain, nausea, and general malaise typically develop 1 to 3 days before the more obvious onset of chills and high fever.
Okay.
Nausea and vomiting are quite common, affecting many patients. The duration of untreated illness averages about 12 days, indicating a prolonged and debilitating course without intervention.
And the rash, is it as variable and elusive as the RMSF rash?
The rash occurs in approximately half of all patients, but it often presents challenges for identification. It's present in only 13% of patients at the initial presentation for medical care, usually around 4 days after fever onset.
Only 13% initially.
Yes. It then appears an average of 2 days later in about half of the remaining patients. The initial macular rash, flat red spots, is often faint and can be best detected by careful inspection of the axilla or the inner surface of the arm. It subsequently becomes maculopapular, slightly raised spots, involving the trunk more often than the extremities, and is seldom petechial, small spots from bleeding under the skin. It rarely involves the face, palms, or soles. Like epidemic typhus, it's detected in only about 20% of patients with darkly pigmented skin, highlighting the challenge of spotless typhus.
What about internal organ involvement for murine typhus beyond the skin?
Pulmonary involvement is frequently prominent and a significant complication. About 35% of patients have a hacking, non-productive cough, and 23% who undergo chest radiography show pulmonary density suggestive of interstitial pneumonia, pulmonary edema, and pleural effusions, with bibasilar rales, crackling sounds in the lungs, being the most common physical sign.
Okay.
Less common but severe clinical manifestations include abdominal pain, confusion, stupor, seizures, ataxia, coma, and jaundice.
And the key lab findings for murine typhus?
Clinical laboratory studies frequently reveal anemia and leukopenia, low white blood cell count, early in the course, followed by leukocytosis, high white blood cell count, later. Thrombocytopenia, low platelet count, hyponatremia, low blood sodium, hypoalbuminemia, low blood albumin, and increased serum levels of hepatic aminotransperases, indicating liver stress, are also common.
Similar pattern to others then?
Yes, quite similar. Prerenal azotemia, a form of kidney injury, can also occur. Complications can include respiratory failure, hematemesis, vomiting blood, cerebral hemorrhage, and hemolysis, destruction of red blood cells. Severe illness often necessitates intensive care admission for about 10% of hospitalized patients.
Right.
Greater severity is generally associated with older age, underlying chronic diseases, and interestingly and critically, treatment with a sulfonamide, which can worsen outcomes in rickettsial diseases. The overall case fatality rate for murine typhus is about 1%.
How is it diagnosed and treated with precision?
Serologic studies of acute and convalescent phase serum samples are the mainstay for diagnosis, showing a rise in specific antibodies. An immunohistochemical method for identifying typhus group-specific antigens in biopsy samples has also been developed and can be useful.
Okay.
Cultivation of the organism is infrequently used and not widely available in most clinical settings, and PCR of the blood is not adequately sensitive for routine diagnosis. When endemic typhus is suspected, patients should be treated empirically with doxycycline, 100 milligrams twice daily by mouth for 7 days.
Doxy again.
Yep. This prompt treatment is crucial. Chloramphenicol, ciprofloxacin, and azithromycin are considered less effective alternatives, but may be used in specific situations where doxycycline is contraindicated or unavailable.
So doxycycline is once again the main player. Now let's move on to scrub typhus, which, from what you've said, has some truly unique genetic and antigenic characteristics that set it apart. #hashtag scrub typhus, Orientia tsutsugamushi, the distinct antigenic challenger.
Scrub typhus, caused by Orientia tsutsugamushi, truly stands apart within this family. It differs substantially, both genetically and in its cell wall composition, notably lacking lipopolysaccharide, which is typically found in other gram-negative bacteria.
No LPS. Okay.
Yeah, this makes it quite unique within this group and affects how our immune system recognizes it and how some antibiotics might work.
And its epidemiology. How is it maintained and transmitted, particularly in its unique environmental niche?
Orientia tsutsugamushi is maintained by transovarial transmission in trombiculid mites, commonly known as chiggers. This means the infection passes from generation to generation within the mite population.
Okay, through the mite's eggs.
Right. After hatching, only the infected larval mites, which are the only stage that feeds on a host, inoculate the organisms into the skin when they bite. These infected chiggers are particularly likely to be found in areas of heavy scrub vegetation, overgrown fields, and transitional zones between forests and cleared land, especially during the wet season when mites lay their eggs. This defines its specific ecological niche.
So it's tied to specific environments and seasons, leading to the name scrub typhus. Where is it endemic, and is it a re-emerging threat?
Scrub typhus is indeed endemic and re-emerging in a vast geographic area, often referred to as the Tsutsugamushi Triangle, encompassing eastern and southern Asia, northern Australia, and islands of the western Pacific and Indian Oceans.
Okay.
Infections are highly prevalent in these regions. In some areas, over 3% of the population is infected or reinfected each month, highlighting a significant public health burden.
Monthly reinfection. That sounds like immunity doesn't last long, which is unusual for many bacterial infections.
You've picked up on a key challenging characteristic. Immunity to a homologous strain, meaning the exact same strain, typically wanes over 1 to 3 years.
Wow.
Furthermore, the organisms exhibit remarkable antigenic diversity, meaning there are many different genetic variants of Orientia tsutsugamushi. This diversity leads to a loss of cross-protective immunity, meaning immunity to one strain may not protect against another, and this loss can occur in as short a period as 1 month.
1 month? That's incredible.
It is. This antigenic variation means you can get reinfected with different strains repeatedly, making long-term immunity or vaccine development incredibly challenging. And interestingly, emerging cases in Chile and parts of Africa are now challenging the classic geographic epidemiology of scrub typhus, suggesting its geographical reach might be wider than previously understood.
What are the clinical manifestations of scrub typhus? Does it present with the classic triad often associated with these diseases?
The illness can vary widely, from mild and self-limiting to rapidly progressive and fatal. After an incubation period, typically ranging from 6 to 21 days, onset is characterized by fever, headache, myalgia, muscle aches, cough, and gastrointestinal symptoms. Surprisingly, the classic triad of symptoms, an Escher, regional lymphadenopathy, swollen lymph nodes in the area of the bite, and a maculopapular rash, is actually less common in indigenous patients of endemic areas.
Less common.
Yes. In fact, less than 50% of Westerners who contract the disease develop an Escher, and less than 40% develop a rash, which, if present, typically appears around day 4 to 6 of illness. This makes diagnosis challenging if relying solely on textbook presentations.
Right.
Severe cases typically manifest with encephalitis and interstitial pneumonia due to the underlying widespread vascular injury. The case fatality rate for untreated classic cases is about 6%, but this figure would likely be lower if all mild undiagnosed cases were accounted for.
How is scrub typhus diagnosed and treated effectively, especially given its unique features and high prevalence in certain regions?
Serologic assays, such as indirect fluorescent antibody, IFA, indirect immunoperoxidase, and enzyme immunoassays, OSAN, are the mainstays of laboratory diagnosis for scrub typhus, typically demonstrating a rise in antibody titers.
Okay.
PCR amplification of Orientia genes from Eschers is an effective diagnostic tool, particularly when an Escher is present, but it's less sensitive for blood samples, especially in early disease. For treatment, patients are typically given oral doxycycline at 100 milligrams twice daily for 7 to 15 days, or azithromycin at 500 milligrams for 3 days, or chloramphenicol at 500 milligrams 4 times daily for 7 to 15 days.
Okay, a few options there.
Yes. It's important to note that some cases of scrub typhus in Thailand have shown poor responsiveness to doxycycline or chloramphenicol, but respond well to azithromycin and rifampin, highlighting regional variations in drug susceptibility and the need for local epidemiological awareness.
All right, let's shift our focus to two more distinct groups of obligate intracellular bacteria, Ehrlichioses and Anaplasmosis, which belong to the Anaplasmataceae family. What makes this family so specialized in how they interact with host cells?
The Anaplasmataceae family consists of obligately intracellular organisms across 5 genera: Ehrlichia, Anaplasma, Wolbachia, Candidatus, Neoehrlichia, and Neoricketsia. These bacteria are truly specialized. Unlike the Rickettsiaceae, which target endothelial cells, these reside specifically in vacuoles within hematopoietic cells, which are our blood-forming cells, including various types of white blood cells and sometimes, though less commonly, endothelial cells. They have a unique tropism for these immune cells.
So they actually hide out inside specific blood cells, almost like a Trojan horse?
Exactly. This intracellular lifestyle allows them to evade the immune system. Specifically, 4 Ehrlichia species, 2 Anaplasma species, and 1 Neoehrlichia species are tick-transmitted to humans, causing potentially severe infections.
Okay.
For example, Ehrlichia chiefensis and Ehrlichia mirus subsclerensis predominantly infect mononuclear phagocytes, like monocytes and macrophages, while Ehrlichia ewingi and Anaplasma phagocytophilum infect neutrophils, another type of white blood cell.
Interesting specificities.
Yeah. Interestingly, Candidatus Neoehrlichia micarensis has been reported to grow in endothelium and Anaplasma capra in human erythrocytes, or red blood cells. This specificity of cell targeting is a hallmark of their biology.
Fascinating how they target specific cell types within our blood and their transmission mechanism. Is it primarily ticks again?
Yes. The Ehrlichia, Candidatus Neoehrlichia, and Anaplasma species are primarily maintained by horizontal tick-mammal-tick transmission.
Tick-mammal-tick.
Right. This means they cycle between ticks and various mammalian reservoirs in nature. Humans, once again, are inadvertently infected, becoming accidental hosts in this cycle when bitten by an infected tick. We are not part of their sustained natural transmission cycle.
You mentioned Wolbachia and Neoricketsia too. Are those direct human pathogens in the same way?
Not exactly. Wolbachia are particularly interesting because they have a unique relationship with human filariasis, which is a parasitic worm infection. They are critical for the viability and pathogenicity of filarial worms themselves.
Oh, wow.
In fact, antibiotic treatment targeting Wolbachia is a well-established strategy for controlling filariasis, rather than directly treating a human bacterial infection by Wolbachia.
So you treat the bacteria to treat the worm.
Precisely. As for Neoricketsia, these organisms parasitize flukes, a type of parasitic flatworm or trematode, that in turn parasitize aquatic snails, fish, and insects.
Ugh.
Only one human Neoricketsiosis has been clearly described. Senetsu fever, an infectious mononucleosis-like illness first identified in 1953. It's associated with the ingestion of raw fish containing Neoricketsia senetsu-infected flukes.
Raw fish, okay.
So for humans, these are less common direct bacterial pathogens and often tied to other parasitic cycles or specific dietary exposures.
Let's focus now on human monocytotropic ehrlichiosis, HME. This sounds like a stealthy threat given its non-specific early symptoms. #tag human monocytotropic ehrlichiosis, HME, Ehrlichia, the stealthy threat.
As of January 2020, over 20,732 cases have been reported to the U.S. Centers for Disease Control and Prevention, CDC. However, active prospective surveillance has documented a much higher incidence, as high as 414 cases per 100,000 population in some U.S. regions, suggesting significant underreporting and a much larger burden of disease than raw numbers indicate.
Right.
Most infections are geographically concentrated in the south, central, southeastern, and mid-Atlantic states, but cases have also been recognized in California, New York, New England, and Midwestern states, showing a broader reach.
And the vector for HME, the specific tick involved.
The Lone Star tick, Amblyomma americanum, is the primary vector for Ehrlichia sheffinensis, and it's notably expanding its geographic range, meaning the risk areas for HME are also growing.
Expanding range. That's concerning.
It is. White-tailed deer are a major reservoir for the bacteria in nature, and dogs and coyotes also serve as reservoirs, often without showing clinical signs themselves, making them silent carriers. Tick bites and exposures are frequently reported by patients in rural areas, with 64% of infections occurring between May and July, which is peak Lone Star tick activity. The median age of HME patients is 55 years, but 11% of infections occur in children under 19, and these can include severe and fatal cases, highlighting the vulnerability of younger populations.
Right.
About 59% of patients with HME are male. Ehrlichia sheffiensis has also been detected beyond the U.S., in South and Central America, Africa, and Asia, making it a global concern.
What are the clinical manifestations of HME once someone is infected? Does it share that non-specific initial presentation?
It absolutely shares that initial non-specific pattern. Ehrlichia sheffiensis disseminates hematogenously through the blood from the dermal blood pool created by the feeding tick. After a median incubation period of 8 days, illness develops.
Okay.
The clinical manifestations are often undifferentiated, very similar to early rickettsial diseases.
Yeah.
Fever in 97% of cases, headache in 70%, myalgia, muscle aches in 68%, and generalized malaise in 77%.
Very common symptoms.
Yes. Less frequently observed symptoms include nausea, vomiting, and diarrhea in 28% to 57% of patients, cough in 30%, a rash in 29% overall, though only 6% at initial presentation, making it an unreliable early sign, and confusion in 20%.
This sounds like it can be quite severe, requiring significant medical intervention.
It definitely can be. HME is a serious illness. An alarming 77% of patients with confirmed cases are hospitalized, and 2% die, despite modern medical care.
77% hospitalized.
Yeah. Life-threatening complications are a significant concern and can include renal failure, meningoencephalitis, acute respiratory distress syndrome, ARDS, a severe clotting disorder mimicking DIC-like syndrome, pneumonia, septic shock, cardiac failure, hepatitis, and hemorrhage. Immunocompromised patients, those with underlying conditions like diabetes, cancer, organ transplantation, asplenia, no spleen, hepatitis C, or HIV infection face a 2.3 relative risk for death, meaning they're more than twice as likely to die from HME.
What about the lab findings for HME? Are they distinctive enough to aid in diagnosis, even if not definitive on their own?
Laboratory findings are particularly valuable in the differential diagnosis of HME, especially when combined with clinical suspicion and tick exposure history. About 66% of patients have leukopenia, a low white blood cell count, which initially presents as lymphopenia, low lymphocytes, and later as neutropenia, low neutrophils.
Okay.
Thrombocytopenia, low platelet count, is very common, affecting 86% of patients, and 89% have elevated serum levels of hepatic aminotransferases,
Yeah.
indicating liver stress.
Right, those key indicators again.
Yes. Despite often low blood cell counts, the bone marrow is frequently hypercellular, and non-case-eating granulomas can be present upon biopsy. A key characteristic to remember for HME is that vasculitis, the inflammation of blood vessels, is not a component of HME, which helps distinguish it from the spotted fever rickettsiosis, where vascular damage is central.
Ah, that's a key difference.
Yeah.
How is HME diagnosed, especially given its potentially fatal nature and the need for prompt treatment?
Since HME can be fatal and progresses rapidly, prompt empirical doxycycline treatment is absolutely critical, as we've stressed for other rickettsial diseases.
Right.
Without it, studies show that 39% of patients with HME require admission to an intensive care unit, and 40% require mechanical ventilation measures that are necessary in no patients receiving prompt empirical treatment. Furthermore, hospital stay and illness duration are significantly lengthened in untreated patients by 8 and 12 days, respectively.
So don't wait for confirmation. Act on suspicion. What specific signs should elevate suspicion?
The diagnosis is strongly suggested by the combination of fever, a known tick exposure in the preceding 3 weeks, thrombocytopenia and/or leukopenia, and increased serum aminotransferase activities.
Okay.
While morulae, which are characteristic bacterial aggregates within infected cells, can sometimes be demonstrated, they are seen in less than 10% of peripheral blood smears, so their absence doesn't rule out HME.
Less than 10%. Not very reliable then.
Not for ruling it out, no. Confirmation during active infection is best achieved by PCR amplification of Ehrlichia sheffiensis nucleic acids in blood, ideally obtained before the start of doxycycline therapy, as antibiotics can reduce bacterial load and PCR sensitivity. Retrospective serodiagnosis, used for confirming past infection, requires a consistent clinical picture and a fourfold increase in Ehrlichia chaffinensis antibody titer to at least 128 impaired serum samples obtained about 3 weeks apart. It's also important for diagnostic precision that separate specific diagnostic tests are necessary for HME and human granulocytotropic anaplasmosis, as they are distinct infections with different serological responses.
Now, what about other Ehrlichia species, like Ewingia ehrlichiosis? Are they similar to HME? Hashtag tag Ewingia ehrlichiosis and Ehrlichia mirus occlurensis infections?
Yes, Ewingia ehrlichiosis, caused by Ehrlichia ewingi, resembles the Ehrlichia chaffinensis in its tick vector, Amblyomma fumanum, the Lone Star tick, and its vertebrate reservoirs, which include white-tailed deer and dogs. Separately, Ehrlichia mirus occlurensis causes human infections after exposure to Caecilioscapularis ticks in specific Midwestern U.S. states like Wisconsin and Minnesota. Both Ehrlichia ewingi and Ehrlichia mirus occlurensis illnesses are clinically similar to, but generally less severe than, HME. Many cases, particularly of E. ewingi, occur in immunocompromised patients, highlighting their particular vulnerability.
Right.
There have also been documented cases of subclinical ehrlichemia, meaning the presence of bacteria in the blood without symptoms caused by Ehrlichia canis in humans. A challenge here is that no specific serologic diagnostic tests for these other Ehrlichia are readily available, and Ehrlichia chaffinensis serologic tests can sometimes be positive even when the infecting agent is one of these other species, leading to potential misattribution and diagnostic confusion.
What about Candidatus neoehrlichia mycorensis infection? That's quite a mouthful and sounds quite new. Hashtag Candidatus neoehrlichia mycorensis infection.
It is quite a mouthful. Candidatus neoehrlichia mycorensis is a bacterium that falls into a fascinating phylogenetic clade, meaning a distinct evolutionary branch between Ehrlichia and Anaplasma.
Okay.
It was first identified in Ixodes ricinus ticks in the Netherlands, and subsequently in mice and Ixodes ovatus ticks from Japan. Through advanced genetic analysis, this organism has been identified as the cause of severe and sometimes prolonged febrile illnesses in European immunocompromised patients with a history of tick bites or exposures. It also causes milder febrile illnesses in Chinese patients after being bitten by Ixodes persilicatus and Haemaphysalis cancina ticks. The clinical presentation is similar to those of HME and human granulocytotropic anaplasmosis, often involving fever, headache, and myalgia, but specific diagnostic methods, while developed, are not yet widely available in most clinical laboratories, making it a challenging emerging infection to diagnose.
So doxycycline is the standard for all these ehrlichioses too. It seems to be a recurring theme for rickettsial diseases. Hashtag tag treatment of ehrlichioses.
Yes, that's correct. Doxycycline is consistently the drug of choice. Doxycycline is highly effective for HME as well as other ehrlichioses, including Ehrlichia ewingia and the Ehrlichia mirus occlurensis infections. Its use in Candidatus neoehrlichia mycorensis infection is also associated with disease resolution.
Good.
Therapy with doxycycline, either orally or intravenously at 100 milligrams twice daily, or tetracycline, 250 to 500 milligram orally every 6 hours, has been demonstrably shown to lower hospitalization rates and significantly shorten fever duration.
Okay.
It's important to note that Ehrlichia chaffinensis is not susceptible to chloramphenicol in vitro, making its use controversial and generally not recommended. While a few reports document Ehrlichia chaffinensis persistence in humans, this is rare. Most infections are cured by short courses of doxycycline, continuing for 3 to 5 days after the fever resolves, if you're best.
Right.
Though poorly studied for this specific indication, rifampin may be a suitable alternative when doxycycline is contraindicated, such as in pregnancy.
And prevention of ehrlichioses, I assume, is similar to other tick-borne diseases we've discussed. Hashtag prevention of ehrlichioses.
Absolutely. The prevention strategies for HME, Ehrlichia ewingi ehrlichiosis, Ehrlichia morris ehrlichiosis, and Candidatus neoehrlichia mycorensis infection all revolve around avoidance of ticks in endemic areas. This includes using protective clothing, applying tick repellents, conducting careful post-exposure tick searches, and promptly removing any attached ticks. All these measures collectively diminish the risk of infection by preventing the tick from feeding long enough to transmit the bacteria.
Now let's talk about human granulocytotropic anaplasmosis, HGA. How does it compare to ehrlichiosis, and what are its distinct characteristics? Hashtag human granulocytotropic anaplasmosis, HGA, Anaplasma phagocytophilum, shared vectors, distinct pathogens.
HGA, caused by Anaplasma phagocytophilum, shares quite a bit with ehrlichiosis, particularly in its transmission route. As of January 2021, over 45,186 cases have been recorded to the CDC in the U.S., mostly concentrated in the upper Midwestern and Northeastern regions.
Okay, upper Midwest and Northeast.
Right. Its global geographic distribution is notably similar to that of Lyme disease, and this is because they share the same Ixodes tick vectors, including Ixodes scapularis, the black-legged tick or deer tick in the eastern U.S., Ixodes ricinus in Europe, and Ixodes pacificus and Ixodes persoccatus in other parts of the world.
So if you're in an area with Lyme disease, HGA is also a significant concern given the shared vector.
Exactly. This co-occurrence is crucial for clinicians. Natural reservoirs for Anaplasma phagocytophilum include white-footed mice, squirrels, and white-tailed deer in the U.S., and red deer in Europe, maintaining the cycle in nature. HGA incidence typically peaks from May through July, coinciding with peak Ixodes tick activity. But exposure to these ticks means the disease can potentially occur throughout the year in some regions. It often affects males, about 59% of cases, and older individuals, with a median age of 51 years.
What are the clinical manifestations of HGA? Does it also present in that non-specific flu-like way initially?
While seroprevalence rates are high in endemic regions, suggesting that many individuals develop subclinical, asymptomatic infections without ever knowing it, the incubation period for HGA is typically 48 days.
Okay.
Disease onset is almost universally characterized by fever in 75% to 100% of cases, myalgia, muscle aches in 73%, headache in 82%, and profound malaise, general discomfort in 97%.
Very high rates for those symptoms.
Yes. A minority of patients develop nausea, vomiting, or diarrhea, about 20% to 40%, cough in 27%, or confusion in 17%. A rash in HGA is uncommon, seen in only 5% of cases, and almost invariably reflects co-infection with Borrelia, the agent of Lyme disease, resulting in the characteristic erythema migrans rash.
Ah, so the HGA itself rarely causes a rash.
Correct. Most patients with HGA develop thrombocytopenia, low platelet count, in 80% of cases, and and/or leukopenia, low white blood cell count, in 63%, along with increased serum hepatic aminotransferase levels, indicating liver stress, in 80%.
And what about life-threatening complications for HGA?
These complications occur most often in the elderly and can be severe. They include renal failure, acute respiratory distress syndrome, ARDS, a toxic shock-like syndrome, pneumonia, and a DTIC or sepsis-like syndrome. Meningoencephalitis, inflammation of brain and meninges, is rare in documented cases of HGA, though other neurologic sequelae like brachial plexopathy, cranial nerve involvement, and demyelinating polyneuropathy have been documented, reflecting the systemic inflammatory response.
Okay.
Patients with a pre-existing immunocompromising condition, such as diabetes, those on immunosuppressive medications, individuals with asplenia, no spleen, or arthritis, have a 3.0 relative risk for life-threatening complications, making them 3 times more vulnerable.
Right.
About 31% of patients with HGA are hospitalized, and 7% require intensive care. The overall case fatality rate is relatively low at about 0.3%, but the relative risk for death is significantly higher, 16 times higher, if the infection occurs in a patient with cancer, highlighting the profound impact of host immunocompromise.
So even though Lyme disease and babesia can be transmitted by the same tick, do co-infections make HGA worse or more difficult to treat?
Interestingly, while co-infection with Borrelia burgdorferi, Lyme disease, and Babesia microti, babesiosis, is common due to shared tick vectors, there is little evidence that these co-infections significantly increase the severity or persistence of HGA itself.
Okay.
However, a critical public health concern is that HGA transmission by blood transfusion, including leukoreduced blood or platelets, has been reported in at least 9 cases, including a fatality, which is a key consideration for blood safety and donor screening in endemic areas.
How is HGA diagnosed, especially given its flu-like presentation, to ensure prompt treatment?
HGA should always be included in the differential diagnosis of influenza-like illnesses during seasons with Ixodes tick activity, typically May through December, especially in the context of a known tick bite or exposure. Concurrent thrombocytopenia, low platelets, leukopenia, low white blood cells, or elevated serum levels of alanine or aspartate aminotransferase, liver enzymes, further increase the likelihood of HGA. It's also worth noting that many HGA patients develop Lyme disease antibodies in the absence of clinical findings consistent with Lyme disease.
Okay.
Thus, HGA should be considered in the differential diagnosis of atypical severe Lyme disease presentations, as the symptoms can overlap.
Are there any rapid diagnostic tests for HGA, something that provides immediate answers?
For rapid diagnosis, peripheral blood film examination for neutrophil morley, those characteristic bacterial aggregates within neutrophils, can yield a diagnosis in 20% to 75% of infections, making it a useful microscopic clue.
More or less.
However, it's not always present. PCR testing of blood from patients with active disease, performed ideally before doxycycline therapy has begun, is both sensitive and specific and is the preferred method for acute confirmation.
Right, PCR is key.
Serodiagnosis is retrospective, requiring a four-fold increase in Anaplasma phagocytophilum antibody titer to at least 128 in paired serum samples obtained 1 month apart. Because seroprevalence is high in some regions due to asymptomatic infections, a single acute phase titer is not sufficient for a definitive diagnosis, as it could just reflect prior exposure rather than active infection.
What about Anaplasma capra infection? That's another newly identified Anaplasma species. Hashtag Anaplasma capra infection.
Anaplasma capra infection in humans was first isolated from goat blood and subsequently identified in 28 patients from northeastern China, representing an emerging zoonosis.
From goats, okay.
Patients presented with fever, headache, malaise, dizziness, myalgias, and chills, but these manifestations were generally less severe than those seen in HGA. Hospitalization was recorded for 18% of these patients, and 14% had underlying disorders, including hyperglycemia, hypertension, coronary heart disease, diabetes, and cancer, suggesting vulnerability in those with comorbidities. 5 patients did experience severe manifestations, including one with encephalitic signs, and Anaplasma capra DNA was detected in their CSF, indicating central nervous system involvement. Anaplasma capra is found most often in Ixodes persilicatus ticks in this region.
Right.
Critically, all patients responded to doxycycline treatment and survived, suggesting it's a treatable infection.
And the treatment of HGA, is doxycycline still the gold standard here as well?
Yeah.
Hashtag treatment of HGA?
Yes, consistent with the other Rickettsial diseases. No prospective studies of therapy for HGA have been conducted directly comparing treatments. However, doxycycline at 100 mg orally twice daily is empirically effective and considered the gold standard.
Okay.
Rifampin therapy is associated with improvement of HGA in pregnant women and children when doxycycline is contraindicated due to its potential side effects in those specific populations. Most treated patients defervesce, meaning their fever resolves, within 24 to 48 hours, highlighting the rapid clinical response to appropriate therapy.
And finally, prevention of HGA. What are the key strategies? Hashtag prevention of HGA. HGA prevention, like other tick-borne diseases, primarily requires tick avoidance. This involves wearing protective clothing, using tick repellents, and performing diligent tick checks after being in wooded or grassy areas.
Okay.
It's important to know that transmission can be documented as few as 4 hours after an infected tick bite, so prompt tick removal is incredibly important for significantly reducing infection risk.
4 hours? That's quick.
It is. The quicker the tick is removed, the lower the chance of transmission.
Now let's talk about Q fever and its remarkable agent, Coxiella burnetii. This one has a truly fascinating and unique story, doesn't it? Standing out even among these already unusual bacteria.
Yeah.
Hashtag tag the agent Coxiella burnetii.
It absolutely does stand out. Coxiella burnetii is a small pleomorphic coccobacillus, meaning it can vary in shape with a gram-negative cell wall. It was first isolated in 1935 and initially classified as a Rickettsia due to some shared characteristics. Its presence in ticks, its obligate intracellular replication, its small size, and similar staining characteristics.
However, we now know it is genetically quite distinct from the Rickettsiaceae family and belongs to its own unique group. It possesses a number of truly remarkable and unique features that contribute to its resilience and pathogenesis.
What makes it so unique and resilient, enabling it to survive in such extreme conditions?
Its resilience is truly remarkable, setting it apart from many other bacteria. Coxiella burnetii can survive in extremely harsh environments outside a host for extended periods, even years, without losing infectivity.
Years. Wow.
Yes. Once inside a host cell, particularly macrophages, a type of immune cell that normally engulfs and destroys pathogens, it has a clever mechanism to escape intracellular killing. It actively inhibits the final step in phagosome maturation.
Okay.
Normally, macrophages form a phagosome around engulfed bacteria, which then fuses with a lysosome to become a highly acidic, destructive phagolysosome. Coxiella burnetii prevents this maturation, essentially creating a safe haven for itself. Furthermore, it is uniquely adapted to thrive and replicate within the highly acidic environment of a mature phagolysosome, which is usually a very hostile bactericidal environment. This extraordinary adaptability and manipulation of host cell processes make it a formidable and persistent pathogen.
That is fascinating. So it's not just surviving passively, but actively manipulating its environment inside the cell to its advantage. What about its epidemiology? How is this widespread zoonosis typically transmitted to humans given its environmental persistence? Hashtag tag epidemiology widespread zoonosis.
Q fever is a classic zoonosis, meaning it's primarily an animal disease that can be transmitted to humans. The primary route of transmission of Coxiella burnetii to humans typically occurs by the inhalation of aerosols shed by infected animals.
Inhalation. Okay.
The main sources of human infection are infected livestock, cattle, sheep, and goats. These are the key reservoirs that facilitate human exposure.
So farm animals are the main culprits. Is there a specific time when these animals are most infectious, leading to the highest risk for humans?
Yes, there is a critical period. Parturition, that is, the process of giving birth, is when infected animals are most infectious.
Ah, birthing.
Right. During this period, massive amounts of Coxiella burnetii are present in the fetus, the placenta, fetal membranes, and amniotic fluids. These materials are then readily shed and contaminate the environment, creating a highly infectious aerosol. Even smaller, but still significant amounts of the bacteria can also be shed in milk, urine, and feces of infected animals.
And its environmental persistence. How long can Coxiella burnetii survive outside a host to continue posing a risk?
That's another one of its unique and most concerning features, making it a very difficult pathogen to contain. Once shed into the environment, Coxiella burnetii can remain viable and infectious in manure, hay, and soil for many years, even under harsh conditions.
Many years. Incredible.
Yeah. From these contaminated environmental sources, it can be easily aerosolized again by wind, dust, or even disturbed soil, and then inhaled by humans, even after traveling miles from the source by wind. This explains how large outbreaks can occur without direct animal contact, just from wind-borne contaminated dust from infected farms.
So it's incredibly tough and widespread. Are there other animals beyond livestock that can carry it and potentially contribute to transmission?
Absolutely. A wide variety of other vertebrate animals can serve as hosts for Coxiella burnetii, contributing to its widespread presence in nature. This list includes birds, cats, dogs, rabbits, skunks, raccoons, deer, bears, sloths, kangaroos, and even marine animals.
Wow.
It has also been found in several tick species, though direct tick-borne transmission to humans is rare and not considered a primary route for Q fever.
With its ease of aerosol transmission, its extremely low infectious dose, you said just 1 to 10 bacteria, and its major manifestation being pneumonia, I can see why it's on the bioterrorism list.
Precisely. Coxiella burnetii is considered a potential bioterrorism agent for exactly those reasons. It can be easily dispersed as an aerosol. The infectious dose required for human infection is incredibly low, probably between 1 and 10 viable bacteria, and its major manifestation in humans is pneumonia, which can be severe, widespread, and lead to significant public health burden.
So who is most at risk for Q fever from natural exposure? Are there specific occupational groups?
People at highest risk for Q fever are those with occupational contact with infected animals, particularly around the time of parturition.
Right.
This includes abattoir workers, slaughterhouse workers, veterinarians, farmers, and other individuals who have direct contact with livestock, especially newborn animals or products of conception. Studies show a significantly high seroprevalence in these occupational groups. For example, 22% of U.S. veterinarians were found to be seropositive, compared to only about 3% of the general population, highlighting their elevated risk.
Are there other less common transmission routes besides inhalation of aerosols?
Yes, though they are less frequent than airborne transmission. Coxiella burnetii can be shed in milk for weeks to months after parturition, and an outbreak specifically associated with the ingestion of raw milk has confirmed the oral route of transmission, though it's generally uncommon.
Okay.
In rare instances, person-to-person transmission has been documented following labor and childbirth in an infected woman during an autopsy of an infected individual, or through blood transfusion, underscoring the potential for less obvious spread. Multiple outbreaks involving laboratory staff have also been reported in the past due to handling contaminated samples. There's even some evidence to suggest that Coxiella burnetii can be sexually transmitted among humans. Unusual modes include transmission through treatment with live fetal sheep cells, which caused cases in 6 people in Germany, and percutaneous infection after crushing an infected tick between the fingers.
So it's truly a global pathogen with multiple, sometimes unusual routes of spread. Where is it found geographically?
Coxiella burnetii infections occur in most geographic locations worldwide, with the notable exceptions of New Zealand and Antarctica.
Not in New Zealand.
Interesting.
Right. Several factors influence its epidemiology. including environmental conditions such as high concentrations of animals, high animal pregnancy rates, dry weather, and the strength and direction of winds, all of which facilitate aerosol spread and long-distance transport. In addition to differences between strains of Coxiella burnetii, inherent variability in human susceptibility influences transmission and disease development. Some people become seriously ill, others have only mild, non-specific symptoms that don't lead them to seek medical attention, and about 60% experience asymptomatic seroconversion, meaning they get infected and develop antibodies without ever feeling sick or having noticeable symptoms.
60% asymptomatic.
Yeah, it's quite high.
Where does it remain particularly endemic, meaning constantly present at high levels? Q fever continues to be endemic in Australia and France. In Cayenne, French Guiana, it's actually hyperendemic, accounting for a staggering 40% of all community-acquired pneumonias, making it a critical consideration for any respiratory illness in that region.
40% of pneumonias, it's huge.
It is.
And there was a truly massive Q fever outbreak in the Netherlands a few years ago, wasn't there? The largest recorded.
Yes. The largest known outbreak of Q fever occurred between 2007 and 2010 in the Netherlands. Over 4,000 human cases were reported, and it's estimated that more than 40,000 people were infected, underscoring the immense public health impact.
Wow.
This outbreak was attributed to a complex interplay of factors. High-density goat farming in areas with large urban populations, combined with specific environmental factors like low vegetation density and higher groundwater concentrations in affected farms, which likely facilitated aerosolization and widespread environmental dissemination of the bacteria. It was a stark lesson in zoonotic disease control.
What about demographics? Are certain age groups or genders more susceptible to symptomatic disease?
Young age seems to be protective against symptomatic disease caused by Coxiella burnetii. In a large outbreak in Switzerland, symptomatic infection occurred 5 times more often among individuals over 15 years of age than among younger individuals.
Okay, older people more affected.
Generally, yes. This suggests an age-related susceptibility to developing clinical illness, even if exposure is similar. And in many outbreaks, men are affected more commonly than women, though the reasons for this difference are not entirely clear.
So let's now explore the clinical manifestations of Q fever, which can cover an incredibly diverse spectrum of disease, from mild to life-threatening. What does acute Q fever typically look like? #, clinical manifestations, a spectrum of disease.
Acute Q fever has an incubation period ranging from 3 to 30 days. One of the fascinating aspects for a professional to note is that the primary manifestations actually differ geographically, which is quite unusual. During the large Dutch outbreak, and also in Canada and Croatia, pneumonia was the more common clinical presentation, often with cough and lung involvement. However, in some countries where Q fever is endemic, like France and Israel, hepatitis, meaning inflammation of the liver, is more common.
Pneumonia versus hepatitis, interesting difference.
Yeah, these geographic differences could reflect the predominant route of infection ingestion of contaminated milk leading to hepatitis, or inhalation of contaminated aerosols leading to pneumonia, or even subtle strain differences in the bacteria.
What about pregnancy? Are there specific sequelae or risks for pregnant women who contract acute Q fever?
The sequelae of infection in pregnant women also vary geographically, which is another intriguing observation. In the Dutch outbreak, severe outcomes in pregnancy were rare. However, in other regions, acute Q fever during pregnancy has resulted in a high incidence of adverse outcomes. Premature birth in 35% of cases, and tragically, abortion or neonatal death in 43%. Lower infant birth weight has also been reported up to 3 times more often among women seropositive for Coxiella burnetii in some areas, suggesting a long-term impact on fetal development.
And what about the less common but still important manifestations of acute Q fever beyond pneumonia and hepatitis?
Beyond the most common presentations of pneumonia and hepatitis, less common but significant manifestations of acute Q fever can include pericarditis, inflammation of the sac around the heart, myocarditis, inflammation of the heart muscle, the calculus cholecystitis, gallbladder inflammation without stones, pancreatitis, lymphadenitis, swollen lymph nodes, spontaneous rupture of the spleen, transient hypoplastic anemia, reduced red blood cell production, hemolytic anemia, destruction of red blood cells, hemophagocytic lymphohistiocytosis, a severe immune disorder, optic neuritis, inflammation of the optic nerve leading to vision loss, and erythema nodosum, a skin condition causing painful red lumps.
Quite the list. A true great mimicker.
It really can be.
What about the more general symptoms of acute Q fever? How does it typically present from the patient's perspective?
The symptoms are often nonspecific, contributing to diagnostic delay. Common ones include a persistent fever, often high, extreme fatigue and malaise, photophobia, sensitivity to light, and a severe, frequently retroorbital headache behind the eyes.
That headache sounds distinctive.
It often is quite severe. Patients often experience chills, sweats, nausea, vomiting, and diarrhea. A persistent cough develops in about half of patients who present with Q fever pneumonia. A nonspecific rash may also be evident in 4% to 18% of cases, though it's often not distinctive.
Okay.
Splenomegaly, enlarged spleen, is seen in 25% of patients, and hepatomegaly, enlarged liver, in 20%. Interestingly, clubbing the enlargement of the fingertips can sometimes develop during recovery. Biochemical markers of autoimmunity, such as anti-cytoplasmic antibodies, ANCA, anti-nuclear antibodies, ANA, anti-smooth muscle antibodies, or antiphospholipid antibodies, are often present in acute Q fever, indicating a broad immune activation.
Right.
Chest radiography can show opacities similar to those seen in pneumonia caused by other pathogens.
So it can be a really debilitating illness. But what about the Q fever fatigue syndrome? That sounds like a long-term lingering effect after the acute illness. Hashtag tag Q fever fatigue syndrome.
It is indeed a significant long-term consequence. Prolonged fatigue follows acute Q fever in up to 20% of cases and can be accompanied by a constellation of other debilitating symptoms, including persistent headaches, sweats, arthralgia, joint pain, and myalgias, muscle aches.
20%. That's a lot.
It is. Several hypotheses exist regarding its complex etiology. One theory suggests a biopsychological etiology, where Coxsackie burnetii acts as a trigger for the development of chronic fatigue. Other hypotheses involve host and genetic factors or ongoing cytokine dysregulation even after the acute infection is cleared.
And is there an effective treatment for this chronic fatigue? Do antibiotics help?
This is a critical point for clinical practice and patient education. A randomized controlled trial, including 155 patients with strictly diagnosed Q fever fatigue syndrome, showed unequivocally that long-term treatment with doxycycline did not reduce fatigue severity compared to a placebo.
So antibiotics are a no-go.
Correct. Antibiotics should not be prescribed for these patients. While cognitive behavioral therapy, CBT, aimed at addressing fatigue-related thoughts and behaviors, was effective in reducing fatigue severity in the short term, the beneficial effect of this treatment was unfortunately not maintained after 1 year, indicating the profound and persistent nature of this syndrome and its complex management challenges.
That's important for people to know, to manage expectations and avoid inappropriate antibiotic use. Let's talk about the big one for Q fever, the most severe and challenging manifestation. The chronic form, which has its own specific set of diagnostic and treatment complexities. Hashtag tag chronic Q fever, preferred term, formerly persistent Q fever.
Chronic Q fever is arguably the most challenging and serious manifestation, developing in 1% to 5% of patients after a primary infection. The most frequent manifestations are endocarditis, infection of the heart valves, and infected aneurysms or infected vascular processes.
So it predominantly targets the cardiovascular system, especially damaged or prosthetic structures.
Precisely. The primary infection often goes entirely unrecognized or was asymptomatic, meaning the patient never even knew they had acute Q fever.
Wow.
The duration between that initial, often silent infection and the manifestation of chronic infection can be several years. The largest observed interval between acute infection and diagnosis of chronic Q fever was over 9 years. This makes tracking the initial exposure very difficult and highlights the insidious nature of the disease.
What are the key risk factors for developing chronic Q fever? Who is most vulnerable to this long-term severe form?
Key risk factors for progressing to chronic Q fever include any pre-existing valvulopathy, heart valve disease, or prior valve surgery, existing aneurysms, presence of vascular prostheses, like artificial blood vessels, renal insufficiency, kidney dysfunction, older age, an immunocompromised state, for example, from disease or medications, and underlying malignancy, cancer.
Okay.
Diagnosing chronic Q fever is profoundly difficult because patients often present with very nonspecific symptoms, such as persistent fever, night sweats, unexplained weight loss, profound fatigue, and general malaise. Crucially, fever can even be absent or low grade, and common inflammatory markers like C-reactive protein, CRP, are often low or even normal, which can be highly misleading to clinicians.
How does chronic Q fever endocarditis differ from other types of bacterial endocarditis, and why is it so hard to diagnose?
Chronic Q fever endocarditis presents quite differently from endocarditis caused by other, more common bacteria. It often manifests as subtle endothelium-covered nodules on the valves, an aortic root abscess, or new or rapidly increasing valve insufficiency. Because C. burnetii is so difficult to culture, it presents as culture-negative endocarditis. which is a significant diagnostic challenge. A very high index of suspicion is absolutely necessary for timely diagnosis, as patients are often ill for over a year before the diagnosis is finally made.
A year.
Yes, it should always be suspected in any patient with culture-negative endocarditis. Additionally, any patient with known valvular heart disease, an aneurysm, or a vascular prosthesis who presents with unexplained weight loss, fever, stroke, unexpected aneurysm growth, or progressive heart failure should be thoroughly tested for Coxiella burnetii infection.
Are there other manifestations of chronic Q fever besides cardiac and vascular involvement?
Yes. Other manifestations of chronic Q fever include persistent lymphadenitis, swollen lymph nodes, and bone infection, including vertebral osteomyelitis, spinal bone infection, and prosthetic joint infection.
Okay.
In a study of 249 patients with proven chronic Q fever in the Netherlands, a staggering 61% developed significant complications. The most frequently observed complications were acute aneurysms, heart failure, and non-cardiac abscesses.
61%.
Yeah, a particularly severe complication occurring in 1 in 6 patients with vascular chronic Q fever was the development of an arterial fistula, including aortoenteric fistula between aorta and gut, aortocaval fistula between aorta and vena cava, aortobronchial fistula between aorta and airway, and arteriocutaneous fistula between artery and skin, which are extremely serious and life-threatening.
What are the risk factors for these complications, and what's the mortality rate for chronic Q fever, even with diagnosis?
PCR positivity at any time during the disease course, the presence of prosthetic material, like artificial valves or grafts, and older age were all significantly associated with developing complications. Tragically, Q fever-related mortality was a substantial 25% in patients diagnosed with chronic Q fever after the large Dutch outbreak, even with modern medical care.
25% mortality, even with care.
Yes. The mortality rate was highest in patients with both endocarditis and vascular infection at 33%, followed by patients with vascular infection only at 25%, and was lowest in endocarditis patients alone at 12%. This underscores the severity of this chronic infection and the critical need for early and aggressive management.
That's a significant mortality rate, even with diagnosis. So how is Q fever actually diagnosed with the precision required, especially distinguishing acute from chronic forms? What are the key tools and how are they interpreted? Hashtag diagnosis of Q fever precision is key.
Diagnosing Q fever, particularly its chronic forms, truly requires precision and a multifaceted approach. While culture of Coxiella burnetii from Buffy coat blood samples or tissue specimens is possible, it requires a biosafety level 3, BSL-3 laboratory, due to its high infectivity and the risk to laboratory personnel, making it not routinely available in most clinical settings.
So how is it usually done in practice? What's the gold standard?
The detection of antibodies to Coxiella burnetii is the most commonly used and practical method. The indirect fluorescent antibody, IFA assay, is considered the gold standard, though ELISA and complement fixation tests are also available.
IFA.
IF tests are particularly useful because they can both detect the presence of antibodies and, crucially, discriminate between acute and chronic infection by differentiating antibody responses to different forms of the bacteria. This differentiation relies on what are called phase 1 and phase 2 antigens, which are distinct forms of the bacteria's outer coating that our immune system recognizes differently, offering excellent sensitivity and specificity.
Can you explain a bit more about how you use serology, specifically the phase I and phase 2 antigens, to diagnose acute versus chronic Q fever? Why is that distinction important?
Sure. For acute Q fever, diagnosis is dependent on seroconversion, which is defined as a 4-fold increase in IgG titer for phase 2 antigens between acute phase and convalescent phase serum samples, typically collected a few weeks apart.
Phase 2 for acute.
Right. In the very first 1 to 2 weeks of illness, before antibody responses are robust, PCR on blood or serum can also be positive, detecting the bacterial DNA directly.
Okay.
For chronic Q fever, the key serologic finding is a high-phase IgG titer, for example, consistently greater than or equal to 1.800 or 1.1024, depending on the lab and assay.
High phase I for chronic.
Exactly. This high-phase IgG indicates a persistent, deeper infection. While highly suggestive, this high-phase IgG alone is not enough for a definite diagnosis of chronic Q fever. A positive PCR for C. burnetii in blood or tissue, in the absence of an acute infection, definitively confirms a diagnosis, but blood PCR is often negative in the majority of chronic patients, and tissue samples are frequently very difficult or invasive to obtain.
Right.
So for chronic Q fever, it's rarely a single test that clinches the diagnosis.
So it's not just one test that clinches the diagnosis for chronic Q fever. It sounds like a complex puzzle that needs to be assembled.
Exactly. The diagnosis of chronic Q fever should always be based on a comprehensive evaluation, integrating a combination of clinical symptoms, laboratory findings, and imaging criteria. There's been ongoing debate on the optimal set of criteria due to the disease's complexity, but the Dutch literature-based consensus guideline is widely recognized as one of the most sensitive and easy-to-use frameworks for making this difficult diagnosis.
Can you walk us through those criteria for chronic Q fever? It sounds like a systematic framework that elite professionals would use to make a precise diagnosis.
Certainly, understanding this framework is key to mastering Q fever diagnosis. According to the Dutch consensus guideline, there are 3 tiers of diagnosis. 1, proven chronic Q fever. This is the highest level of certainty, requires either 1, proven chronic Q fever, a positive Coxiella burnetii PCR in blood or tissue in the absence of an acute infection, which is important to rule out new exposure, or an IFA titer of at least 1.80 or 1.1024 for Coxiella burnetii phase I, IgG, and definite endocarditis according to the modified DO criteria, which are standard criteria for endocarditis, or proven large vessel or prosthetic infection by advanced imaging studies such as FDG, PTE, CT, MRI, or AUS aortic ultrasound.
Okay, proven is quite specific.
Yes. Then there's 2. Probable chronic Q fever. This level is diagnosed with strong evidence, but without full confirmation as proven, it requires an IFA titer of at least 1.8 or 1.1024 for Coxiella burnetii phase I, IgG, and at least one of the following supporting manifestations. An IFA titer of at least 1, a valvulopathy, heart valve disease, not meeting the major DO criteria, but still suggestive. An IFA titer of at least 1, a known aneurysm and/or vascular or cardiac valve prosthesis without definite signs of infection on initial TEAT, transesophageal, transthoracic echocardiogram, PK, CT, MRI, or AUS, but still a site of potential infection. An IFA titer of at least 1, suspected osteomyelitis, bone infection, or hepatitis as a manifestation of chronic Q fever. An IFA titer of at least 1, pregnancy, as it's a known risk factor. An IFA titer of at least 1, persistent symptoms and signs of chronic infection like unexplained fever, weight loss, night sweats, hepatosplenomegaly, enlarged liver and spleen, and persistently raised ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein, which are general inflammatory markers. An IFA titer of at least 1, granulomatous tissue inflammation proven by histologic examination, biopsy. An IFA titer of at least 1, an immunocompromised state.
Right, a collection of suggestive findings.
Exactly. And finally, 3, possible chronic Q fever. This is the most general category, indicating a suspicion but less specific evidence. It's defined simply by an IFA titer of at least 1.800 or 1.1024 for Coxiella burnetii phase IgG, without any of the specific clinical manifestations that would meet the criteria for proven or probable chronic Q fever. In these cases, watchful waiting and further investigation are often needed rather than immediate aggressive treatment.
Got it.
This tiered system ensures that the diagnosis is made systematically, based on a growing body of evidence, vital for such a complex disease.
Imaging obviously plays a very big role here, particularly with cardiac and vascular involvement. What are the key imaging modalities used and what do they reveal?
Imaging is indeed crucial for identifying the deep-seated infections of chronic Q fever. Valvular vegetations, which are abnormal growths on heart valves characteristic of endocarditis, are detected in only 12% of patients with Q fever endocarditis by transthoracic echocardiography, TTE, which is the standard ultrasound of the heart through the chest.
Only 12%.
Yeah, not great. However, the detection rate is significantly higher, between 21% and 50%, with transesophageal echocardiography, TEE, where the ultrasound probe is placed down the esophagus, providing a much clearer view of the heart.
So T is much more sensitive for heart valve involvement. What about more advanced imaging like PET scans?
Fluorodeoxyglucose positron emission tomography combined with CT, FDG PET-CT, is a particularly powerful and increasingly utilized tool for diagnosing chronic Q fever, especially in cases where the infection is difficult to localize.
Okay.
It works by detecting areas of increased metabolic activity, which is characteristic of inflammation and infection. It can detect not only prosthetic valvular infection, but also intravascular infection elsewhere in the body, osteomyelitis, and lymphadenitis, allowing clinicians to pinpoint hidden infection foci.
So it can spot infection in places other tests might miss or where symptoms are nonspecific.
Exactly. For native valve endocarditis, the specificity of FDG PET-CT is very high, but its sensitivity can be low, meaning a normal scan cannot definitively exclude native valve endocarditis. However, a study involving 273 FDG PCT scans in patients suspected of chronic Q fever show that even after serology, PCR, and often ultrasound or CT had been performed, FDG-PCT still led to a 1.9-fold increase in definite endocarditis diagnoses, when FDG uptake in a heart valve was added as a major criterion to the Duke criteria.
Wow, nearly doubled the diagnoses.
Of 218 scans performed during follow-up, 57% resulted in treatment adjustment, clearly demonstrating its utility in guiding therapy and monitoring response. Therefore, in cases of suspected or confirmed chronic Q fever, FDG-PCT should definitely be considered as an essential diagnostic and monitoring tool.
This sounds like one of the most complex and prolonged infections to treat. How is Q fever managed, especially chronic Q fever? #tag treatment of Q fever complex and critical.
Treatment of Q fever, especially the chronic forms, is indeed complex and critical, often requiring prolonged courses and careful monitoring. In vitro, Coxiella burnetii is susceptible to a range of antibiotics, including doxycycline, quinolones, trimethoprim, sulfamethoxazole, TMP-SMX, macrolides, and rifampin. While antimicrobial susceptibility testing is not routinely performed in clinical practice, and doxycycline resistance isn't common, resistant isolates do exist and can emerge.
What about acute Q fever? What's the standard treatment there?
Treatment of acute Q fever with doxycycline, 100 milligrams twice daily for 14 days, is usually successful and leads to prompt resolution of symptoms. Quinolones are also effective alternatives. If acute Q fever is diagnosed during pregnancy, where doxycycline is generally avoided for prolonged courses, treatment with TMP-SMX is recommended for the duration of the pregnancy, balancing efficacy with safety concerns.
Can chronic Q fever be prevented from developing after an acute infection, particularly in high-risk patients? Is there a prophylactic approach?
Yes, this is a crucial area for preventing devastating long-term outcomes. Prophylaxis should be considered. A combination of doxycycline and hydroxychloroquine for 6 to 12 months after acute infection should be considered in patients with specific risk factors. Pre-existing valve abnormalities, a prosthetic heart valve, an aneurysm, or a vascular prosthesis.
Okay, doxy plus HCQ.
Right. This regimen has been shown to be effective in preventing progression to chronic Q fever in patients with valvulopathy. However, the exact indications and duration of prophylaxis should always be based on a careful, individualized consideration of the potential benefits weighed against possible side effects for that patient.
Now, for chronic Q fever, what's the favored treatment regimen? And why is it so specific, requiring a combination of drugs and such a long duration?
Decisions on treating chronic Q fever are exceptionally challenging, and consultation with an infectious diseases expert is highly recommended for optimal management.
Right.
It's crucial to understand that there is no indication for antibiotic therapy in those with possible chronic Q fever, which is defined only by an elevated phase IgG without clear symptoms or an identifiable infectious focus.
Okay.
For confirmed chronic Q fever, the favored regimen is a combination of doxycycline, 100 milligrams twice daily, with hydroxychloroquine, 200 milligrams 3 times daily.
Why hydroxychloroquine? That's not typically considered a primary antibiotic. What's its unique role here?
That's the key and most fascinating aspect of this treatment. Hydroxychloroquine actually plays a crucial synergistic role, rather than being a standalone antibiotic. It works by alkalinizing the phagolysosome, which is the highly acidic compartment within the macrophage where Coxiella burnetii resides and thrives.
Changes the pH.
Exactly. By making this compartment less acidic, hydroxychloroquine significantly changes the environment, which then renders doxycycline bactericidal against Coxiella burnetii. Without hydroxychloroquine, doxycycline alone might only be bacteriostatic, meaning it inhibits bacterial growth but doesn't actively kill the bacteria.
Makes it kill the bug, not just stop it.
Precisely. This synergistic effect, promoting bacterial killing rather than just inhibition, is absolutely crucial for successful treatment and eradication of chronic Q fever.
So it essentially makes the primary antibiotic more effective. What about monitoring and risks for this prolonged complex regimen?
Monitoring is intensive and crucial. It's advised to determine serum doxycycline levels, aiming for concentrations between 5 and 10 milligl to ensure therapeutic levels are achieved and maintained.
Okay.
Patients treated with this regimen must be thoroughly advised about 2 significant risks: photosensitivity, increased skin sensitivity to sunlight, and, critically, retinal toxicity associated with hydroxychloroquine.
Retinal toxicity. Serious.
Yes. They should be evaluated by an ophthalmologist before starting treatment and every 6 to 12 months during the entire course of therapy to monitor for any retinal changes. Despite potential side effects, these should not easily lead to cessation of therapy, given that this appears to be the most effective approach for this very serious infection, which, as we discussed, carries a high mortality even with treatment.
Right.
The benefits of treatment far outweigh the risks of these side effects if managed properly.
Are there alternative regimens if doxycycline hydroxychloroquine cannot be used due to contraindications or severe side effects?
Yes, alternatives are considered, but they are generally less preferred due to less robust data. If the favored doxycycline hydroxychloroquine combination cannot be used, the regimen chosen should ideally include at least 2 antibiotics active against Coxiella burnetii. In a study including 322 patients with chronic Q fever, treatment with doxycycline combined with a cannelone appeared to be a safe alternative. But it's important to note it's not as well established as the combination with hydroxychloroquine.
And the treatment duration for chronic Q fever sounds incredibly long, often measured in years. Why is it so protracted?
It is indeed protracted, reflecting the intracellular nature and resilience of Coxiella burnetii. The minimum treatment duration is 18 months for native valve endocarditis and other manifestations without prosthetic material.
18 months minimum.
Yes, for patients with prosthetic valve endocarditis or infected vascular prostheses, it's an even longer minimum of 24 months. Many patients with a vascular infection, particularly if they have extensive disease or complications, may require even more prolonged treatment before the infection fully resolves and they are considered cured.
Right.
Surgical intervention is also often necessary, for example, to remove an infected graft or prosthetic valve if antibiotic therapy alone fails. And localized abscesses need to be drained for antibiotic therapy to be successful.
How do clinicians determine if a patient is cured after such a long and arduous treatment? What are the criteria for success?
Defining cure for chronic Q fever after the minimum treatment duration is complex and based on a combination of factors, as there's no single definitive marker. A 4-fold decrease in phase IgG antibody titers and the disappearance of phase 2 IgM antibodies is considered a favorable prognostic indicator for patients with Q fever endocarditis, suggesting a successful immune response to treatment. But ultimately, cure is operationally defined by a combination of imaging improvement if there were initial abnormalities, for example, resolution of vegetations, reduced inflammation on peaky scans, a sustained decline of serologic titers, particularly the phase I IgG, over time, persistent negativity of PCR on blood or serum samples indicating no detectable bacterial DNA, and crucially, significant and sustained improvement of symptoms and clinical well-being, the holistic assessment over time.
So follow-up is obviously critical given this complexity, even after treatment ends. #tag follow-up of Q fever.
Absolutely. Long-term follow-up is paramount for Q fever. After acute Q fever, patients without known risk factors for developing chronic Q fever should still be evaluated clinically and serologically at 6 months to ensure complete resolution and no subtle signs of progression.
Okay.
For patients with a very high risk of developing chronic Q fever, those who are on prophylaxis, are immunosuppressed, or have other significant risk factors, follow-up with serology and PCR every 3 to 6 months for 2 years is highly recommended to catch any potential progression early.
And what about during chronic Q fever treatment, and even after it's completed?
During chronic Q fever treatment, patients should be followed every 3 months to evaluate symptoms, monitor for drug side effects, and assess serology and PCR results to gauge treatment response. If new complications are suspected, imaging should be repeated. Even after the end of the very long treatment course, relapse has been described up to 5 years later, sometimes even longer.
5 years. Wow.
Yeah. Therefore, it is strongly recommended to continue monitoring patients with serology and PCR for a minimum of 5 years after treatment cessation. This long-term vigilance is essential to detect any recurrence promptly and initiate further therapy.
And finally, let's talk prevention for Q fever. Is there a vaccine available, or are public health measures the primary strategy? #tag prevention of Q fever.
Yes, there is an effective vaccine. A wholesale vaccine called QVax, licensed in Australia, has been highly effective in preventing Q fever, particularly for high-risk occupational groups like abattoir workers.
Okay, QVax in Australia.
Right. The vaccine is administered only to people without a prior history of Q fever and who have negative results in both serologic and skin testing, which is performed with the diluted Coxiella burnetii vaccine to assess prior exposure or immunity. This rigorous screening is crucial because vaccinating someone who has already been exposed can lead to severe local reactions.
Right.
This vaccination program has dramatically reduced cases among abattoir workers in Australia, demonstrating its efficacy.
Beyond vaccination, what about animal husbandry practices to prevent widespread environmental contamination?
Good animal husbandry practices are incredibly important in preventing widespread contamination of the environment by Coxiella burnetii, especially on farms.
Makes sense.
These practices include isolating aborting animals for up to 14 days, raising feed bunks to prevent contamination of feed by animal excreta, carefully destroying aborted materials, such as by burning and burying fetal membranes in stillborn animals, and wearing masks and gloves when handling any aborted materials. Vaccination of sheep and goats, combined with a culling program for infected animals, was also highly effective in controlling the massive Netherlands outbreak, highlighting the importance of integrated animal and public health strategies.
And for public health during an outbreak, are there specific measures to prevent human-to-human transmission or other forms of spread?
Yes, during an outbreak of Q fever and for 4 weeks after it ceases, blood donations should not be accepted from individuals who live in the affected area.
Okay, blood donation restrictions.
Yes, this measure is crucial to prevent transfusion-related transmission, as Coxiella burnetii can be present in the blood of asymptomatically infected individuals, posing a risk to recipients. Hashtag tag outro.
What an incredible journey we've taken today. We've truly embarked on a comprehensive deep dive into the diverse and complex world of rickettsial diseases. From the tiny, seemingly innocuous vectors like ticks and mites, to the profound and often devastating impact these obligate intracellular bacteria can have on human health, and the significant diagnostic and treatment challenges they present, it's clear these are far from simple infections.
We've certainly moved beyond the surface, striving for mastery.
We really have. We've unpacked the crucial nuances of each disease, their specific vectors, their unique geographic ranges, and their distinct clinical presentations, even when they start with those shared, non-specific early symptoms.
Right.
Understanding the subtleties, from the pathogenesis of increased vascular permeability in RMSF to the long-term multi-drug treatment required for chronic Q fever, and the intricate diagnostic criteria that elite professionals use, truly separates the well-informed from the casually aware. This level of detail is what allows for real understanding and preparedness.
So what does this all mean for you, our listener, now armed with this deeper understanding? Considering the remarkable adaptability of these obligate intracellular bacteria, their ability to jump between diverse hosts and persist in challenging environmental conditions for years, what hidden lessons do they teach us about the ongoing intricate dance between microbial evolution and human vulnerability? That's a great question. And considering how easily some of these agents can be aerosolized and the formidable challenge in their early diagnosis, what implications does this deeper understanding have for public health preparedness in an increasingly interconnected world? These aren't just obscure medical facts. They're vital pieces of a larger puzzle about how we interact with our environment, anticipate unseen threats, and ultimately protect ourselves and our communities.
We encourage you to carry this deeper knowledge with you, letting it subtly change your perception of everyday environments, perhaps making you more mindful on your next outdoor adventure, or how you approach unusual, persistent symptoms in yourself or others. It's that kind of insanely curious spirit that drives discovery and ultimately fosters a more informed and healthier world. Thank you for joining us for this deep dive.